Great. Good morning. I'm calling this roundtable to order. Today is Thursday, May 4th, 2023. The time is now 9:31 a.m. I am at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today, we are holding an oversight roundtable to hear from experts and two district agencies on the best strategies for moving forward after the end of the federal public health emergency on May 11th. COVID upended our everyday lives 3 years ago. On January 31st, 2020, the Secretary of Health and Human Services certified a public health emergency due to COVID-19. Under the declaration, the administration addressed public health concerns by purchasing vaccines and tests, requiring insurance providers to cover COVID treatments, providing free home tests, and implementing Medicare and Medicaid flexibilities to mitigate the effects of the pandemic on enrollees' access to care. The coming transition period will mark a significant moment in history as we begin to emerge from the COVID pandemic and the public health emergency. To promote clarity and accuracy today, I ask all of the witnesses to specify relevant dates because end dates for varying programs and flexibilities. The federal public health emergency will end 1 week from today on May 11th, 2023. President Biden signed a bill to end the national emergency, which is distinct from the public health emergency, on April 10th, 2023. Medicaid recertifications resumed on April 1st, 2023. DC Alliance recertifications resumed July of 2022, and some Medicaid flexibilities will run through the end of the calendar year. The post-emergency phase of the pandemic will require that we have clear and specific plans in place to address the ongoing threat of seasonal surges or new variants of COVID. This includes ensuring access to once-free resources that are not available, such as booster shots, vaccines, testing, and masks for all district residents. I hope to hear DC Health's plan on how to partner with pharmacies to distribute vaccines and boosters. It is important that we maintain affordable access to vaccine and boosters, even as the pharmaceutical industry looks to raise prices. I am concerned by reports that the COVID-19 vaccine doses could start upwards of $130 per person, which would place a significant burden on our residents. I am interested to hear from our experts about the plans to address this issue and ensure that everyone has access to these life-saving treatments. In addition to these important issues, I hope to hear an update from the Department of Healthcare Finance on the early progress of Medicaid recertifications, including details on direct community outreach, wait times, and the number of people who have recertified thus far. I would also like to hear more about how the department who refers people to the DC Health link and any waivers or flexibilities for health professionals who accept Medicaid that will elapse. Finally, I'm concerned about restrictions on telehealth services under Medicaid and would like to hear more about the availability of these services for our residents. We will hear from two panels of expert witnesses today. The committee intentionally invited experts with a broad range of expertise and perspectives. Each witness will have 5 minutes for opening remarks before we have time for discussion. We'll then turn to Dr. Sharon Lewis, who's the interim director of DC Health, as well as Wayne Turnage, who is the director of the DC Department of Healthcare Finance. I want to thank you all for being here today. And in an interesting, we're talking about the end of the pandemic, our witnesses are here in person with us. Not just our government witnesses who have been here in person for, I'd say the start of this year, but also our witnesses, our expert witnesses this morning. So I will now call up the first panel of witnesses. Robin Rudowitz, the VP and Director of Program on Medicaid and the Uninsured from the Kaiser Family Foundation. Joan Alkler, Research Professor at Georgetown University McCourt School of Public Policy, and Executive Director of the Georgetown University Health Policy Institute for Children and Families. Marie Nolan is the Dean and Ordinary Professor of Conway School of Nursing at the Catholic University of America, and Hugh Mighty, who is the Senior Vice President for Health Affairs at Howard University, and is also the former Dean of the Howard University School of Medicine. Good morning to each of you. Okay, so just in terms of ground rules, we haven't had our public witnesses here in a while. You just need to hit the button in front of you to turn your mic on. And then you see the clocks in front of you and you can begin when you get started. So Robin?
Great. Good morning. Thank you for the opportunity to provide a high-level overview of what the end of the federal public health emergency for COVID-19 means for Medicaid. As everyone is aware, the COVID-19 pandemic resulted in an array of changes at the federal level, including multiple emergency declarations, legislation, and administrative actions. There were also policy changes for states and the district. Collectively, changes helped to expand access to COVID-19 vaccines, testing, and treatment, but also had broad implications for the entire healthcare system. Given the short amount of time that I have for remarks today, I wanted to highlight pandemic-related changes in Medicaid in three key areas: telehealth, home and community-based services, and Medicaid enrollment. As the PHE ends on May 11th, many policies will expire, resulting in decisions for states that will have implications for enrollees. I'll start with telehealth. While states used telehealth prior to the pandemic, all states, including DC, used emergency authorities to increase access to care through expanded use of telehealth. States were able to expand telehealth modalities to include audio-only delivery of services and also expand the range of services available to be provided via telehealth. These expansions were particularly impactful for increasing access to behavioral health. In a KFF survey, most states reported plans to make at least some changes permanent. States are also implementing initiatives to evaluate and assess quality and prevent fraud or misuse of telehealth going forward. For example, in our last survey, DC reported adding new claiming codes to monitor audio-only telehealth services. Going forward, DC and across the country, it will be important to watch how telehealth policies evolve to be able to continue to expand access, but also to ensure that services meet quality and clinical effectiveness standards. Next, I want to highlight pandemic changes to Medicaid HCBS. HCBS are services provided in people's homes and other non-institutional settings to help people with activities of daily living, such as eating, bathing, and dressing. They are provided to people who need such services because of aging, chronic illness, or disability, and may include personal care, adult daycare, and home health aid services. During the pandemic, states used an array of emergency authorities to increase access to HCBS services. Some common policies included virtual evaluations for eligibility, providing services via telehealth, and allowing family caregivers to be paid providers, and increasing some utilization limits. In our survey of HCBS programs, DC had reported adopting all four of these policies. Going forward in DC and across the country, states will need to make decisions about whether to continue these policies put in place, or if policies expire, requiring transition plans to mitigate the effects on enrollees. The third and most far-reaching Medicaid pandemic policy to watch is the unwinding of the Medicaid continuous enrollment provisions. Early in the pandemic, federal legislation prohibited states from disenrolling people from Medicaid to ensure stability and coverage in exchange for increased federal matching dollars. Federal legislation enacted at the end of 2022 delinked these policies from the PHE and set an end date of March 31st. Largely due to the continuous enrollment provision, national enrollment in Medicaid and CHIP reached 93 million people in January 2023, an increase of 22 million people, or 31% from February 2020. It was about 20% in DC. Over the next year, all Medicaid enrollees will be redetermined for Medicaid coverage, and beginning in April, May, or June, DC is expected to start in June, individuals may be disenrolled from Medicaid if they're no longer eligible or if they face barriers with renewal. Nationally, we expect that millions will lose Medicaid during the unwinding and could become uninsured if they remain eligible for Medicaid but are disenrolled, or if they do not transition to another type of coverage. CMS has been providing guidance about policies that can help promote continuity of coverage, and I'll highlight a few. States and DC can and do have a lot of efforts underway to work with providers, managed care plans, and a broad group of stakeholders to do outreach and communication about upcoming renewals, and also encourage enrollees to ensure that contact information is updated. In discussion groups with enrollees, we know that there is variation in how enrollees like to receive information. So sending communication through multiple modalities like mail, email, text, and through online accounts can help reach a larger share of enrollees. Ensuring that information is easy to understand, available in multiple languages, and providing assistance without long waits in person and through call centers can help ensure that people can navigate renewal processes. In addition, following up on returned mail or with enrollees who haven't responded to their renewal requests before terminating coverage can really help to ensure that people who remain eligible are not disenrolled. Other key policies that can promote continuity of coverage include adopting 12-month continuous coverage for children, a policy that can help to prevent churn of enrollees on and off coverage going forward, and ensuring a use of ex parte or passive or auto renewals that are done based on using available data. Adopting key policies is critical, but also having feedback loops to understand how policies are being implemented and working in real time will be critical to understanding how the unwinding is unfolding and if people are able to retain coverage. So with that, I will stop right on time, I hope. And I really look forward to hearing from the other panelists as well as answer any questions.
Thank you, Robin. We'll have some questions. Joan?
Thank you, Madam Chair. I'm really excited to be here today with you on a matter of such importance in my hometown, where I've lived for the last 34 years and raised my family. So for the purposes of my remarks, I'm going to refer to DC as a state, since that is both my and your aspirational goal, and the way that DC is considered for the purposes of the Medicaid discussion. So Robin did a great intro. This is an issue of grave importance. We know that millions will lose Medicaid across the country, but the stakes are especially high for children. According to a recent analysis we did at Georgetown CCF, where we used administrative data rather than census data, which tends to undercount Medicaid participation, Medicaid now covers, or I should say in 2022, Medicaid was covering 54% of all children nationwide. And here in the district, we ranked second in the country. In New Mexico was first, if you're curious, with just about 75% of children on Medicaid, 3 out of 4 in the District of Columbia. So you can see how high stakes this is for children. I'm going to emphasize 3 points on the unwinding process. Robin alluded to this. The more states can do passive or ex parte renewals using existing data sources, the better. That's the best way. We understand that agency officials have said they expect to do about 77% of renewals for the income-related populations, excuse me, through this method. And I hope that's right. That would be good news. That's certainly something to keep an eye on. I think one of the big challenges facing the district and many states across the country is shorting staffages. And we're very concerned about that, having adequate staffing to handle calls, in-person questions from families, from providers, from pharmacists, right? We may have a mom go and try to get her kid's asthma inhaler prescription filled, and then they say, oh, sorry, it's not covered. And that's how she may find out that her child has lost coverage. So this is going to take a village, but it's going to take enough staff to really make sure this process runs smoothly. So that's one key point. The second I would say is the district should really commit to public release of all of the data that is required to be submitted to federal CMS in real time. This includes data that's mandated by federal law, such as procedural denials, call center statistics, including wait times, and transfers to the marketplace, i.e. DC HealthLink. All states have to submit this data to the federal CMS on the 8th of every month. And so that would be great to make that public in real time. Some states are doing more than the minimum of what is required by federal law, like Minnesota, which has a terrific data dashboard that will disaggregate data by region and by race and ethnicity. So that would be great. Finally, I would suggest, and I think this is true of every governor in the state, the mayor should commit to hitting the pause button if things are going wrong. If we see a great deal of children in particular losing coverage, because we know that children, 3 out of 4, and that's probably even higher here in DC, will remain eligible for Medicaid. So if we see large numbers of procedural denials, especially for children, the mayor should hit the pause button and figure out what's going wrong. Finally, to get a little broader, while in the past, the district has ranked as one of the best states for low children uninsured rates, reaching an all-time low and leading the country really with just under 99% of children covered in 2017. The number of uninsured children has been going in the wrong direction in the last few years. It's a little funky with the data sample size, but in our most recent report looking at this, just over 96% of children were covered in 2021, and DC had dropped in the rankings to 16 out of 51. So of course, that trend in the wrong direction could really accelerate if this unwinding goes wrong. It has actually been a silver lining of the pandemic for families that they haven't had to worry about gaps in coverage because of this continuous coverage protection. And as Robin mentioned, Congress mandated in the Consolidated Appropriations Act that laid out the terms of Medicaid unwinding that all states had to provide children continuous coverage for 12 months in Medicaid and CHIP. That mandate will come into effect January 1st, 2024. It's unfortunate to me the district had not already picked up this policy, which has been a state option for many years, and about half the states have already done it. But now the district will be required by federal law, and if they could pick that up early, that would be great. Moreover, to really even envision a brighter day for children and families, we do have leader states like Oregon and Washington State that have received federal Section 1115 waiver approval to cover young children from birth to age 6. Continuous coverage through that period, no red tape, no renewals. That's been an exciting, again, lesson of the pandemic these states have taken to heart. And in closing, I would encourage you to put DC back at the head of the pack for covering children and consider this bold and visionary new approach so that every parent leaves the hospital knowing their baby is covered and they don't have to worry about that until they go to school, and then their coverage can be checked every year. So thank you so much for inviting me.
Thank you so much, Professor. Dr. Nolan.
Morning, Madam Chair.
Good morning.
I'm very pleased to be invited to this panel today. What I'm going to talk about is both the nursing shortage, what we're doing at Conway School of Nursing at the Catholic University of America to address the nursing shortage, and what we might do together in public-private partnerships to an even greater extent to address the nursing shortage. A 2022 report of the U.S. Bureau of Labor and Statistics projects a 6% growth in the need for new nurses between 2021 and 2031. As our population ages, even more people need nursing care. A 2018 national survey of RNs by the Health Resources and Services Administration revealed that the average age of RNs was 50, and it predicted a large wave of retirements over the next 15 years. That was pre-pandemic, before the wave of early retirements that we're all aware of now. Most concerning is the report of the American Association of Colleges of Nursing out this week on May 2nd, with new data that show enrollment declines in nursing programs across the country for the first time in 22 years. From 2000 to 2021, undergraduate RN programs climbed steadily from 77,000 to 256,000. New 2022 data show an enrollment decline of 1.4%, again for the first time that we've ever seen this decline in 22 years. This decline should concern us all. At the Conway School of Nursing, we're doing our part. Thanks to the generous donations of Mr. Bill Conway and Mrs. Joanne Conway in both scholarship funding and a new building, which will double our class and lab space that's due to open in January 2023, we plan to double the size of our nursing enrollment of our school over the next 5 years. As we work to solve this nursing shortage, one thing remains. What many people do not realize is that a significant factor contributing to the nursing shortage is a nursing faculty shortage. The same American Association of Colleges of Nursing report this week revealed that 78,000 qualified applications in nursing schools around the United States were not accepted due to a lack of sufficient faculty and clinical sites. So applications are down for the first time in years, and yet we're still turning away applicants due to insufficient numbers of faculty. At the Catholic University of America, we've worked together with colleagues at Howard University, George Washington University, and Trinity Washington University to establish a Center for Future Faculty. Thanks to the generous donations of Mr. Bill Conway and Mrs. Joanne Conway and Mr. Joseph Hall and Mrs. Catherine Hall, graduate nurses will now serve as future faculty fellows. They will receive scholarship support to take graduate courses in nursing education at Catholic University and will complete teaching residencies with an experienced faculty mentor at all 4 of our universities. What is needed is to prevent the pipeline of nurses to going dry is unrestricted grants to support tuition as well as cost outside tuition that serve as barriers to enrollment and retention of students in baccalaureate nursing programs, such as books and fees. And we also know that students who hold jobs while they're going to school are less likely to be successful and less likely to complete their registered nursing program. So we need funding that supports not only tuition, but also books and also living expenses. To sustain the pipeline of new RNs in the workforce, scholarship support is needed, therefore, for both undergraduate RN students and for graduate nursing students at the master's and doctoral levels to prepare the next generation of nursing faculty. Private-public partnerships of universities, hospitals, and government are needed that extend from high school programs that first introduce students to nursing to unrestricted grants that fund both undergraduate RN students and graduate nursing students as future faculty. Thank you.
Thank you, Dr. Nolan. Dr. Mighty?
Good morning, Chairwoman Henderson. Thank you for the opportunity to testify along other healthcare experts focusing on the end of COVID as a public health emergency. COVID-19 pandemic has had a widespread impact on all facets of society. It has impacted how we work, how we educate, socialize, deliver healthcare throughout the world. While COVID-19 infections and deaths have lessened, COVID-19 remains one of the leading causes of deaths in the United States, tied to approximately 250 deaths daily, mainly among those who are immunocompromised and elderly, according to April 16, 2023 reports. On May 11, 2023, the COVID-19 Public Health Emergency Declaration will expire, which will officially mark the end of COVID-19 as a pandemic, although the virus certainly will remain with us. Despite this milestone in this fight, it's important that the healthcare community, therefore, continue to remain vigilant in practice and apply lessons learned where applicable to ensure we are prepared for future pandemics. I'll put quotes around that. I believe it's important to at least overview initially how Howard University's critical role in this fight against COVID-19 in Washington, D.C. region has been present. Howard health institutions, including Howard University Hospital, Howard University Faculty Practice Plan, and the health sciences schools have been on the front lines of the fight against COVID-19 since February 2020. In May 2020, Howard established a free COVID-19 community testing site at our Benning Road facility located in Ward 7, and shortly thereafter opened a second COVID-19 community testing site through a partnership with Pennsylvania Baptist Church located in Ward 7 to provide an accessible and convenient way for residents east of the Anacostia to receive testing. In September 2020, Howard established a CLIA certified laboratory to support our District of Columbia COVID-19 testing and support the campus as well as supporting other HBCUs around the nation without access to such facilities. In this way, we're able to provide a safe and healthy environment for faculty, students, and staff to continue operations. The laboratory continues today under the Howard University banner. And to date, we've processed over 163,000 tests. In February 21, we established a COVID-19 vaccine clinic to deploy the life-saving vaccines in coordination with the District of Columbia's Department of Health. Initially, the clinic was open from Monday to Fridays, 9 to 3, but we expanded and flexed as the need during that period arose. It was operated by a diverse and large workforce, which included our 4 health sciences schools, medical residents, volunteers of campus staff, and physicians faculty. The team worked diligently to cultivate an efficient and patient-centric vaccine program to ensure a seamless and enjoyable, if you could consider it enjoyable, experience for district residents. The latter point is essential given the vaccine elicited such a range of sentiments from residents at the time, including joy, anxiety, fear, and apprehension. As medical professionals, we understood these sentiments and undertook proactive measures to ensure medical professionals and patients' information were readily available to address district residents' questions and concerns. Moreover, the team developed various outreach strategies to reach our patients, included but not limited to calls and schedule vaccine appointments for patients that aligned with the current DC health eligibility criteria. We partnered with MCOs to schedule attributed residents for vaccine appointments, instructed our providers to discuss vaccines with patients through regular visits, disseminated emails and text messages to patients via our electronic health record system, and leveraged community partnerships to educate district residents about the importance of receiving the vaccine. On May 2021, Howard University launched a mobile vaccine program to provide a convenient and responsive solution for district residents unable to receive their COVID-19 vaccines at the Howard University site. We paid special attention to communities with health disparities and social determinants of health. The mobile vaccine program collaborated with numerous partners, including but not limited to the District of Columbia Housing Authority and their 7 properties, District of Columbia Public Schools, the Convent House of Washington, Goodwill of Greater Washington, council members Allen and Nadeau, and other community-based organizations to provide COVID-19 vaccine services and educational programs to ensure residents had convenient access to vaccines and information to make informed decisions. Howard learned various lessons during this COVID-19 pandemic. First, traditional and non-traditional partnerships remain central to consistently providing health services to underserved and vulnerable communities. For instance, faith and community leaders, low-income housing providers, and patient advocacy groups provided critical insights to develop community-informed vaccine and health strategies. Second, health and vaccine education programs are essential to building trust with individuals, families, and communities. Third, it is important to invest in leading-edge health and vaccine surveillance capabilities, tools, and programs to ensure the region is adequately prepared to address future pandemics. Fourth, technology will continue to play a significant role with respect to health education and deployment of healthcare services. And lastly, health equity remains an indispensable component of reimagining healthcare delivery for the most vulnerable in the District of Columbia and America at large. In conclusion, Howard remains committed to supporting the District of Columbia's transition to a post-pandemic environment. We stand ready to lend our expertise and human resources to assist the district and DC Health in any manner that deems appropriate. Thank you for the opportunity.
Thank you. And thank you so much to these panel of witnesses. I'm going to ask a round of questions. We've been joined virtually by Councilmember Zachary Parker from Ward 5, who's a member of this committee. So you'll see him on your screens on the side. I feel like I air traffic this way. We'll do 10-minute rounds and then we'll kind of go from there. So first I'll say I'm really excited for this panel. Ms. Rudowitz, thank you so much for being here, but I'm even more excited to have a representation from Georgetown Catholic and Howard. And I feel very strongly that, we have these great resources at our higher ed institutions in the district that we often don't see infused with government and sort of bringing some of your expertise to the forefront. And I think it's also important as we talk about some of the workforce challenges that you all raise, that your students stay here after they get these great educations. And so thank you again for all of you for being here. I wanted to follow up with a few questions. So Professor Alkler, in your testimony, you focused on children, which I think that to provide the statistics that you talked about in terms of 75% of the children in the District of Columbia being receiving their healthcare coverage through Medicaid, that's a very large jarring number, especially when we think about the recertification process. One of the things you talked about was procedural denials. Can you say a little bit more about what that might entail?
Sure. So procedural denials essentially means when somebody loses coverage, and it could be a child or an adult, there's typically a reason code for that, right? What is the reason that they lost coverage? Now, sometimes when a family goes through the renewal process, it will be determined that their income is too high, right? They're over the income limits. So that would be a reason of ineligibility because they don't meet the eligibility rules anymore. But a procedural denial just suggests that for some reason, the family or person has not completed the renewal process successfully.
So a paperwork issue.
Paperwork issue, red tape. I call it a red tape denial. It's really a failure of the process. And for children, especially in DC, where our income eligibility is quite high, most of these children are going to remain eligible. So we know for children, especially, that a lot of procedural denials is a problem because children are not going to have another source of coverage by and large, because employer-sponsored coverage for dependents that's affordable is hard to come by.
Okay. That's definitely something to sort of think about. We know from the DC Alliance recertification process, which has already started, some of the quote unquote procedural denials have been our fault, the fault of the government, in that we had individuals who were submitting their documentation paper at a Dropbox, and then nobody checked the Dropbox for several weeks in that process. And so I think that's definitely something for us to flag, and we'll talk to Director Turnage a little bit about that as well. One of the other things that you mentioned was releasing the data that is already provided to CMS. Is there anything within that CMS data report that contains PPI or anything that the government can reasonably say we cannot disclose this information?
No, I don't believe so.
Okay.
And in fact, I'll just add, the federal government is required to release the data that was part of the Consolidated Appropriations Act. So eventually CMS will release the data,
But
it would
not
be
real time.
quicker, and I hope they're going to move quickly, but it would be quicker just to get it released in real time by the district.
Yeah. You mentioned that Minnesota has a particularly useful data dashboard. And we're going to pull that up on the screen so that folks can see it. Can you walk us through what components makes this one of the better that you've seen?
Sure. So you can see here that they have the renewal dates by month, right? This is a process that states have to complete by May 2024. So taking their time and spacing out the cohorts is important. So that's one important piece. But then you can also see at the top that you can disaggregate. You can select, for example, race and ethnicity. And once they have more data, because they haven't started their unwinding, they're going to be able to disaggregate this data. And I think, and I can't see it super well, but I think there's also, thank you. There's a variety of factor here, enrollee, social vulnerability quartile. So that's exciting to me because that's going to be able to kind of fine tune this. Now, some states have just started releasing data. Arizona, for example, has already started terminating people. They're releasing by eligibility category, which is also helpful to be able to drill down into which kinds of Medicaid beneficiaries are losing coverage.
It would be,
sorry
to interrupt you, but it would be helpful if there were some key categories that you feel like are super important, that you can provide that to the committee that we can sort of pass along.
Sure.
Making no promises, because in this government, anytime we ask them to do a data dashboard, they ask for $500,000 to do it. So we'll see what we can pull together in that time. Dr. Nolan, I want to ask you a little bit about, if you could say a little bit more about the pipeline for nurses in the district. So, you pointing out this data just from this week of the American College of Nursing, it is concerning for so many reasons, but that additional layer that you said of, it's not that people don't want to go to nursing school.
Yes.
It's because we don't have faculty, I think is that's a very interesting component here.
Yes, and I would agree. It's something that many people do not know about. And part of the one of the drivers there is that when you think about who goes back and gets a graduate degree, often by that time they've been a nurse for 5 years or so. Now they're married, now they have children, and they have many financial responsibilities. So it's a great barrier to have to pay for a graduate education and to stop working or work part-time while you're doing it. So there are many reasons it's a challenge for nurses to come back to graduate school and get that additional training.
If you were going full-time for your master's, it would take approximately 2 years.
Correct.
And if you were doing part-time, how long would it take?
3 years.
3. Okay. I think you raised something very interesting because, and it's something I also talked to the Office of the State Superintendent of Education about. Whereas even from the local government support around scholarships for young people, we focus so much on undergrads, which is very important. However, no one ever provides any of the scholarships for graduate level work. And I think it's a real question of like, do I go into X amount, add zeros, thousands of dollars in debt for this additional degree or not? And it's just very few sources available.
Very true. I mean, I'm a scholarship student myself. When I went to Catholic University many years ago, I came to the point of my doctoral program. I was a single person at that time. So I got to the 3-year point. This is for a PhD. And I just ran out of money. And I'd already had 10,000 in debt in loans at that point. So I had to make a personal decision of whether to take another loan out and kind of power through another year, or to drop out for a year, make more money and come back. And I had really considered both things. And when I was deciding, Catholic University came forward and gave me another $10,000 grant. And so, it's really a little bit more tuition support or a little bit more support for those other barriers can really make a difference. I've seen it in my own life and I've seen it in my own students' life. A little additional support can go a long way to resolving this faculty shortage.
Mm-hmm. So let me ask a question for all of the academics, although, well, here at the School of Public Health or School of Public Policy that is attached to the health piece. But one of the things that folks have been concerned about is, in a similar phase of like, after there's a war, there's a decline in the number of people who are signing up to go into the military service. After a pandemic, are we seeing a decline in individuals who are interested in the health profession because of everything that they saw that happen? Is that something that you're seeing at your institutions, Dr. Mighty?
We've seen it both ways. So there's been a rise in certain areas and a decline in others. So the medical school applicants, for example, have not fallen off one bit. In fact, that number has gone up. Yeah. Some of the nursing school issues have gone down somewhat, but now they're rebounding. They're rebounding for some of the same issues that we see. They're being limited by space and faculty, right? We have to teach in some space as you grow, and you have to have enough faculty to do it on demand. But we've seen it go both ways. And I think right now, the trend is towards the upswing as things have stabilized.
Ms. Roberto?
I agree that from national data, we've seen drops and then rebounds, but the other area that's really lagging and not coming back is long-term care workforce. So direct care workers and people who are working in nursing homes are another area where that has remained well below pandemic levels.
Yeah. I have a couple more questions for this panel, but I'm running out of time and I try to model the behavior. So Councilmember Parker.
Thank you. And thank you for everyone on this panel.
Councilmember Parker, are you on mute?
No, can you hear me?
Hold on 1 second. We can't hear you. So if you just give us a minute. Hold on, we need to get assistance from the Secretary's office to turn the volume up in the room. Hold on. Councilmember Parker, can you try to speak again?
Testing, testing. Can you hear me now? Can you hear me
Okay,
now?
hold on 1 second.
Testing, testing. Testing, testing. Can you hear me now?
hybrid.
Councilmember Parker, if you're able to just come upstairs, we'd love to see you in person. Okay, while he makes it, I'm just gonna ask my couple other questions. Ms. Rudowitz, can you say more about the telehealth challenges and how are those flexibilities or how are jurisdictions thinking about allowing these flexibilities in the future? And what can we do to expand that? And I say that as I think telehealth is a great thing, but as we sort of see more, let's say, bad actors from some of the companies in this space, the one that immediately comes to mind is most recent of BetterHealth, which was a mental health telehealth platform that has sold data, essentially. So what can we do to expand on that, but also provide protections?
That's a great question. And I think on the Medicaid side, again, there was telehealth before the pandemic. Of course, there was expanded greatly. And I think to help people who could not get to the doctor's office and to expand access more broadly. That said, I think states and DC are in the process of evaluating what services to continue, again, particularly on the audio only. So how does that balance with quality, misuse, fraud, and clinical effectiveness? So there were lots of services that were expanded. Are all of those services the best for telehealth? You know, are they the best for audio only? So I think while some people say that telehealth was one of the silver linings of the pandemic in terms of expanding access, I do think there's a real effort to look at ways that you can moderate some of the access issues with these protections. Again, DC did add a code to look at those audio only, so able to segregate those to monitor better utilization of audio only services as one step. And some states that had gone audio only for some services are cutting back.
Like what type of services would have been audio?
Like some of the pediatric services are,
So
pediatricians
I
are
described that my kid has a temperature, but you don't see the kid?
well, especially well visits. Sometimes pediatricians were arguing that they really get a much better assessment of a child in an in-person visit. So moderating what types of telehealth, right? If your child is sick, maybe that can be handled over, but a well visit, you're doing a much fuller assessment if you can see a child in person. So all of these things across the spectrum. I do think one area that will probably continue is around behavioral health, where there's just been great expansions of access and not as the sole way to provide those services, but to help mitigate workforce issues as well as access issues.
Great, thank you. We've been joined in the chamber by Councilmember Parker. Councilmember Parker?
Yes, and thank you all for being here today. I'm going to start with Dr. Nolan. And again, thank you for joining. You talked about the nursing shortage, and as Councilmember Henderson alluded to, the nursing faculty shortage, which I too found as an aha moment, as I hadn't realized that there had been a shortage for faculty. But I want to think more broadly of the impact on our medical and hospital systems. And so one of the things that I've heard repeatedly from area hospitals is that the pandemic and their need to outsource to nursing agencies or contract nursing programs really took a toll financially on hospitals. And as a result, many of them are exploring efficiencies, if you will, of how do they cut down on nurses, the needs of nurses. We're even hearing that in DC and how we're nursing schools. And so my question for you is, how are you all as a nursing program preparing, bracing for the future of nurse support in hospitals as more health systems are exploring these efficiencies, which to me seems as though they're trying to do more without nurses. And to me, that seems to be, would pose a challenge for the future nurses that you're preparing.
Well, actually, we welcome efforts to do more without nurses because there's so many things that nurses do in the hospital setting that are really not essential to the nursing role. In fact, I had a Zoom meeting with 7 chief nursing officers of the DC, Virginia, Maryland area last week. And one of their greatest frustrations was that when there's a workforce shortage of dietitian or dietary aides who deliver the trays, when there is a workforce shortage of the laundry personnel who deliver the linen, it always falls to the nurse. So the nurse will be told, at 7 a.m, the trays are not going to be coming up until 10 o'clock today. So the nurses have to get together and say, which patients have diabetes that I have to advocate for immediate, trays? Which ones can wait a little bit longer? And in terms of linen, they get together the same way and say, which one of our patients absolutely has to have linen today? Which ones could get by without it? So nurses, and they might be negotiating both within a unit and across units. So the shortage of other healthcare workers often eventually ends up being more work for the nursing staff. So to the extent that we could manage some of those other workforce shortages, it may be much better for the nurses. Now, the other thing we're doing is working very closely with our clinical partners in hospitals. So, one example, and there are many examples, but one is Sibley Hospital. So Sibley has, and again, these are a lot of examples with donors, with philanthropy, but I think they could be expanded with more resources. So we definitely think that sometimes a new nurse gets into the hospital and just finds out it's not a good fit. Maybe they were looking for more critical care, or maybe they were looking for more community services. So it could be anything. But what we're doing with Sibley is Sibley found a donor who's willing to give a $10,000 scholarship to seniors in their baccalaureate program in exchange for their agreement to do a clinical internship at Sibley in their senior year. And Sibley, for its part, is going to assign a special clinical nurse mentor to that student, and maybe have this nursing student, instead of just on one unit, they may try out 2 separate units or even 3, so that the nurse has a chance to, the nursing student in the senior year has a chance to get to know different units in that hospital and bond with the nurses. And so by the time that student is done with that internship, and Sibley has spent more resources on to bond with that student, then the student will be asked, where do you want to practice in this hospital? And if the student stays for 2 years, there's actually a bonus that the hospital provides for retention, and the student can decide not to accept the 2-year bonus, but instead accept a 3-year bonus. So we're working with our hospital partners to come up with creative ways that would encourage nurses to stay longer, to both find a better match, student hospital match, and we think that better match may lead to longer retention.
Love that. Love that.
Yeah.
Dr. Mighty, you talked about traditional and non-traditional partnerships, and one of the programs that Howard is leading around vaccine education. I recall at the height of the pandemic, one of the challenges for residents in wards 5, 7, and 8 in particular was getting education and information out about vaccines and increasing vaccine access. Can you just speak to what approaches or strategies you've learned that have been successful that we might glean to in the future?
Go to church. And I don't mean that derogatively. Our biggest partners in mobilizing large numbers of people is through the clergy, it's through the church, it's through the ministers. It is a source of trust for our community. And when we partner with them, that's a lot of that transfers, right? So people actually wearing a white coat and going into a room does not really convey the sense of comfort. When your pastor tells you this is okay and we should do it, it has a lot more impact. So whether it be in the District of Columbia or for 5 years I was in Louisiana, when we wanted to make a bold move and introduce something, we went to church. And that is probably one of the larger partnerships that you can mobilize a large number of people at once. So if you just think about, what communities look like, then I mean that sincerely, that our partnerships, aren't just among healthcare professionals. We deliver the service, but to get people to accept the service and to be educated, we need community leaders as strong partners.
Thank you for that. And that resonates, and especially the aspect about trust. As someone that went door to door trying to educate people about vaccine access, while it was appreciated, without that trust level there, there still seemed to be a barrier. So that certainly resonates. I want to come to the Medicaid enrollment, and I will start. And Joan, I'm sorry, I did not catch your last name.
It's Alker.
Alker. You talked about hitting pause if things are going in the wrong direction. What are some of the leading indicators outside of just large numbers of procedural denials, or is that the one that we should focus on to alert us that we should start looking at different strategies?
Yeah, I think that's a really important one. And as I mentioned, particularly for children, if we see a lot of procedural denials, it's a problem for anybody. The other statistic, and I'm not sure what the district has contemplated in terms of call centers to help folks who may be having problems with the renewal process. I know and this is mandated to be reported to the federal government, but call center statistics are a great kind of canary in the coal mine, right? If you've got the call center is really slammed and there's long wait times and people aren't getting through, they're not getting the help that they need. So that's another good one to look at. And then I think it's also might be helpful to disaggregate, and I hope this is going to happen anyway, but by ward, right? So you can see if there's certain parts of the city that are especially seeing large numbers of disenrollments, because maybe there's not enough community support in that area. And I'll just mention a couple of kinds of folks I feel especially worried about here in DC. Families who have a lot of residential instability, relatively poor families who have moved around a lot, and the district has not been conducting renewals. Many states were, but just not acting on them, but the district hasn't. So the address may be out of date. So families with a lot of residential instability, I think, is a key group. Families with a limited English proficiency and or mixed status families would be another group I'd worry about. And then I'd also worry about youth aging out of the child welfare system, because that's a risk point.
Super hopeful. And then Ms. Rudowitz, you talked about the 22 million person increase in enrollment at the height or during the pandemic. Do you have statistics on the use of like Medicaid benefits as it relates to enrollment? Or how many people were taking advantage of those services?
So we're trying to get some of those statistics now at the federal level. CMS has put out some snapshots, and we did see during the height and early in the pandemic drops in utilization. So drops in immunizations for kids, drops in child visits, dental, mental health utilization. So when people weren't getting to the doctor and things were closed down except for emergency services, there were declines. Similar to workforce, we're seeing some rebounding of some of those services that have been missed, but it's unclear whether things are all caught up. We know that there's still depressed rates of immunizations. So I think there's a lot of catch up from things that were paused during the pandemic, and we're still sorting through a lot of those statistics. So some things were picked up by telehealth, but not everything.
Okay, that is my time. Thank you.
Councilmember Barker, we'll do another 5-minute round with this group if you have some additional questions. So Ms. Rudowitz, actually something you brought up triggered another question for me, which is, I think one of the unfortunate aftermaths of the pandemic is that vaccine hesitancy is at an all-time high, not just for COVID, but for all the other vaccines as well. And so, like, even if I would just mention vaccine, people think I'm talking about COVID, but I could be talking about hepatitis B, polio, Tdap, all the other things. So what are some of suggestions that you all have that we need to still continuously be doing in terms of vaccine education for community? Anyone?
I think it's important that we message consistently. We tend to message when something goes awry. So the polio, someone gets polio in some state, and for the news cycle hits it, and then we respond to it, as opposed to a continuous education about the importance of vaccines, the prevention role of vaccines, the potential downfall of not getting vaccines. We do it episodically in a crisis when people may not be listening, and we're driving it with fear. It should be a part of our day-to-day. One of the things we learned when we went into the school system and we were trying to get folks to enroll their kids, one of the messages that we got back was, well, you never educated us. Why should I put my kid to get a vaccine when you just basically told us to get a vaccine? We never got the educational message. So I think it has to be constant, and it has to become a part of the day-to-day thought around these are responsible things that you do as parents or as citizens to help protect yourself.
Anyone else?
I think there were also efforts to group vaccines together, so you weren't constantly getting the next vaccine. So do flu and COVID at the same time. But agree, I think the church issue applies to vaccines as well as the redetermination process. And we know if kids lose coverage, also they're not as likely to be interacting with their doctor and missing that opportunity potentially.
Right. If you had an assessment of our system altogether, and I'll ask this of the next panel too, do you feel like the District of Columbia is prepared for whatever the next pandemic or public health emergency might be? And if not, what should we be doing? So I always, I think we had a HCMA, our Homeland Security and Emergency Management team, was talking to some of the staff. No one likes to fund HCMA because they think they're like, oh, they don't do anything. And then when you need them, you're like, there you are. Glad you exist and that you have supplies, right? So like, this is one of those things of like, what should we be doing to prepare now for whatever that next thing might be?
I'm just going to speak to the Medicaid issue. And as I mentioned, I'll just say my colleagues have been looking a lot at what states are doing, and we do a joint survey with Rob and the Kaiser Family Foundation, and DC didn't really answer a lot of the questions, so we don't have a lot of information, and so unfortunately we don't feel super confident about how this is going to go in DC.
What questions didn't we answer?
Well, we can show you in the tables.
Okay.
But there just wasn't a lot of information provided on a bunch of things, so it's hard to assess. But I think going forward, as I mentioned, it's disappointing that, for example, the district hadn't picked up this continuous eligibility policy for children when it's been a state option for many years. And so it would be great for the district to, as I say, learn from this was a silver lining of the pandemic, that families didn't have to worry about losing coverage or doing their renewal and moving to a new day when we have this. So Oregon is really taking the lead. They're covering infants to age 6. And then after that is 2 years continuous eligibility for everybody. So including adults. And in a place like DC where we have generous eligibility levels, I think that's a good idea. Because unfortunately there isn't a lot of huge income leaps up. So, children especially tend to remain eligible.
I think whether we're talking about another infectious disease epidemic or a growing epidemic of mental health problems in children, or a very large growing population of elderly people who will need care in their homes and in other locations. Nurses are in every setting, and nurses know how to coordinate care across settings. So I think the more we can do now to slow down this decrease in applications to nursing schools, the more we can do to support nurses who are coming into the schools, I think the better prepared we will be for the next disaster that we're facing in healthcare.
I would just say, oh,
No, you can go ahead. Just one thing. The one thing was very evident, and you asked two questions, right? How did DC do? I think DC did very well compared to many other states. They responded quickly. There's a lot of communication. We established, zones to attack the problem, as soon as we could do that. Lessons learned from that is it's manpower. Right. One of the things we learned is that we have traditional roles. We broke all those traditional roles, right? I have 4 health sciences schools, pharmacy, dentistry. All of those students, over 400 students, became our workforce. Right? And we trained many of them how to give vaccines, how to do initial intake things, how to triage, and we did it quickly. Manpower. So again, if we were to prepare for something else, we should have, again, it was episodic, right? We just set it up and we ran with it. If we're going to be preparing for something to come, again, it should be something that's woven into the state's fabric around healthcare, that we train manpower. We don't train them in necessarily traditional roles. Many people can deliver, students who are delivering care, where you would say, oh, a nurse or a doctor or whatever, but we had all 4 health sciences schools involved in delivering care.
Thank you.
I have many colleagues at KFF who tracked state level data around vaccines, treatment cases, deaths. I do know that DC did provide a lot of that data and disaggregate it as much as possible. So I would say mobilizing to release data so you know where the problem is and how to address it is critical. And I would say on the Medicaid side, when we did talk to Medicaid directors across the country, it was clear that the pandemic forced quick responses and different types of relationships and coordination with other agencies. And I think some of those things will be in place, hopefully, for the next pandemic. So people had never spoken to people, Medicaid versus public health versus other social service agencies. So those relationships and that coordination, hopefully, as well as coordinating with other stakeholders in the community, will hopefully be a base for further response.
Thank you. Councilmember Parker.
Yes, Ms. Rudowitz, I want to come back to the Medicaid enrollment, and you talked about folk in DC will be de-enrolled in June. What should we be looking to or supporting or making sure happens before people lose that enrollment?
Yeah, I think Joan touched on some of these issues, but I think right now a lot of education and outreach. To individuals to expect that they may, if there's a problem with the ex parte or passive renewal, that they may get something in the mail that they need to respond to. So I think here, as well as across the country, there are efforts to let people know that this could be coming. So I did see that there's a special piece of mail that will have, some indicator that this is important, you need to pay attention to it. Encouraging people, as Joan said, since renewals have not been taking place, to go, if they have an online account or want to stop by the office, to make sure that their information is updated so that they actually receive that information. All of those things I think can be happening, and providers can help reach out, managed care companies, churches, to let people know that that might be coming. I think some of those are the more important things in advance of starting the process.
Outreach, education about it. Okay, and then just 2 broad questions. One is the fact, and we discussed that people are still dying from COVID. People are still contracting COVID, and it is expected to be with us for a while in the future, even though it seems as though society were ready to move on. How is that impacting your programs and the work that you do generally? And connected to that, what should we be doing to educate the public around just the dangers of disregarding that COVID is still amongst us? Feel free to take either one of those because I only have 3 minutes, but the fact that COVID is still here, how is that impacting the work that you all are doing in your respective spaces?
So we're still have maintained a COVID vaccine funding. It's not so much that we don't have the availability, it's folks aren't coming, right? So again, the messaging should be, I think, more focused on who's most at risk, right? So we know that the elderly, pick a number of age if you want, and those who are compromised and most at risk. And so the concept of making sure that folks are boosted, because COVID has a lifespan, if you will, in terms of the vaccine. Right? The vaccines are less effective the further out you go. And what we've seen is that for the most part, younger populations, those who are not immunocompromised, the vaccine, even though it may have waned, folks are getting infected, but they're not being hugely impacted by that. However, those who are elderly, those who have diabetes, those who have other diseases that are immunocompromised, the cancer patients, those folks need to be reboosted, and we should be focusing an effort at least on that population, because those are your most at risk and those are the people who are still dying.
They should be reboosted. How often, you would say?
You can vary it. It's from anywhere, the CDC says if you're immunocompromised, it could be as short as 2 months, but I'd say certainly within 4 to 6 months, if you have not had a bivalent vaccine, you should be looking to get
And is
one.
that into perpetuity? They should every 6 months just get a booster?
For the data that we have is now, I would say it might be into perpetuity. But again, we don't have a lot of data on the bivalent boosters longer term yet, because so few people have actually taken advantage of it, right?
Got it. Any others want in the last minute, just around how COVID staying with us is impacting the work that you do day to day, from training folk to outreach, getting people signed up for Medicaid? I'm going to take that as a no. Well, thank you all for your testimony. And I would just say in my remaining time, and Dr. Mighty, what you just shared is sticking with me, that we have a responsibility to educate people that COVID is still very real and is impacting people. And my fear is that with the moving away from the declaration of a public health emergency nationally and locally, it will be in a rearview mirror, and our most vulnerable residents and neighbors are going to still be impacted. And so that is sticking with me. And again, thank you all for sharing.
Thank you, Councilmember Parker. Thank you so much to this panel of witnesses. Again, we really appreciate you being here today. I will now call the second panel, Dr. Jacqueline Bowens from the DC Hospital Association, Patricia Quinn from the DC Primary Care Association, Claudia Schlossberg from the DC Coalition on Long-Term Care, and Dr. Suzanne Bathgate, who's the president of the Medical Society of the District of Columbia. Awesome. Dr. Bowens, when you're ready.
Thank you. I appreciate the doctor, but I'm just missed. But thank you so much. I appreciate the extra education. So thank you very much. Good morning, Chairman Henderson and members of the Committee on Health. I'm Jacqueline Bowens, and I'm the president and CEO of the District of Columbia Hospital Association. And I very much appreciate the opportunity this morning to present testimony at this roundtable on the end of the COVID-19 public health emergency. The District of Columbia Hospital Association is the unifying force working to advance hospitals and health systems in the District of Columbia by promoting policies and initiatives that strengthen our system of care, preserve access, and promote better health outcomes for patients and communities they serve. Our overall vision is the development of an efficient and effective healthcare delivery system that supports a healthy and vibrant community in the District of Columbia. I want to start my testimony by thanking the mayor, the council, and the healthcare leadership in the District of Columbia. While we experienced extremely tough times and lost far too many residents to COVID-19, the courageous work of the DC Health under the leadership of Dr. Nesbitt and now Dr. Lewis, as well as the Department of Healthcare Finance under Deputy Mayor Turnage, our hospitals were able to protect residents, healthcare workers, and genuinely save lives because of the investments made in the public health system. From the hospital standpoint, the additional support authorized by the council and provided by Mayor Bowser gave hospitals the critical support they needed to surge, add capacity, purchase equipment and supplies, and address increasing workforce costs. The end of the federal public health emergency on May 11th has many policy and practical implications for district residents and providers. This on top of the unwinding that started with the Consolidated Appropriations Act that Congress passed last year and put in motion the process to end the continuous Medicaid enrollment provisions and phase out of the Enhanced Federal Medical Assistance Percentage, or FMAP. An orderly Medicaid redetermination process is one of the most crucial aspects of the end of the PHE. One of the most devastating and lingering impacts of the pandemic has been delayed care. According to a report by the Urban Institute, about 25% of Americans with chronic conditions reported delaying care during the pandemic. In the District of Columbia, that was approximately 50%. After 3 years, we're still playing catch up in our hospitals. We cannot afford to lose coverage for anyone. We must ensure that district residents maintain coverage, whether through Medicaid, the Alliance, or plan through DC HealthLink. Coverage is essential for residents to maintain equitable access to healthcare, providers and pharmacists to manage chronic conditions and receive comprehensive healthcare. DCHA and our member hospitals are committed to assisting healthcare finance in their work to communicate to residents the need to update their contact information with the department to make sure they receive renewal notices and avoid a lapse in care. When it comes to preparedness and ensuring hospital capacity, those efforts are ongoing. Preparedness is a continuing effort which HEPRA and the DC Health and Medical Coalition lead for the healthcare sector. Throughout the pandemic, hospitals have reported information daily and continue to do so. We expect the district data requirements to be reduced, but do anticipate the CDC's National Healthcare Safety Network, or NHSN, reporting to continue through at least 2024. Currently, that reporting is done daily through the HMC software platform. We are working with HEPRA and HMC to identify opportunities to automate the reporting to provide relief to staff at the facilities. As we've discussed with many of you previously, the biggest challenge for our hospitals' capacity is their inability to discharge patients timely and avoid and the timely availability of healthcare workers. You've heard from others and you'll continue to hear, I'm sure. We've seen some early success through a comprehensive discharge assistance that is now being piloted with a project with healthcare finance. The pilot hospital that we're working with has seen a 50% reduction in prolonged stays, as well as a corresponding reduction in some boarding in the emergency department. Expansion of this program to other hospitals, we hope will increase capacity as well as see a reduction in boarding. But workforce challenges continue to be an issue for our hospital and across the industry. And we're continuing to aggressively recruit to fill vacancies, offering bonuses, incentives, as you heard earlier today, to fill positions, and actively engaging agency personnel to support staff. But to this end, we must continue to eliminate barriers that contribute to workforce shortages or threaten healthcare providers standing as an employer of choice. This includes streamlining the licensing process, accelerating licensing compacts, looking at reimbursement to support living wages, investments in IT system design, and the IT fixes really need to be implemented as soon as possible. To underscore the importance of this, we anticipate over 700 applications for licensure over the next few months and believe that this is going to be the new normal in the time being. And again, I'm sure there'll be questions, so thank you very much for allowing me to testify, and I'm very happy to answer any questions that you may have.
Thank you, Ms. Bowens. Patricia Quinn.
Good morning, Patricia Quinn. I'm the Vice President of Policy and Partnerships at the DC Primary Care Association. Thank you for the opportunity to represent health centers and their patients as we prepare for the end of the public health emergency. Next slide, please. Just to share a bit of data, health centers have delivered over 180,000 tests for COVID. over 160,000 vaccines. 92% of those vaccines were to Black, Latino, and other people of color in the district. Our partners in doing that work include very many of the people in this room today, certainly DC Health, Department of Healthcare Finance, Hospital Association, our association's colleagues, unprecedented collaboration, communication, and shared support. Next slide. Thank you. Not surprisingly, massive shift to telehealth for the health centers. Just sharing a bit of data, I'll be doing some comparisons between 2019 and 2021. We will very soon have 22 data, and I'll update these slides for that purpose. But even as we look at 19 to 21, just 100-fold increase in the numbers of telehealth visits. DHCF's fast movement to make that possible by enabling changes to the ways in which telehealth could be provided, including audio-only telehealth, made a huge difference for the patients of the health centers. DC Health coordinated licensure flexibilities and has made expedited licensure available. All of those things combined to make it possible for people to continue to receive care, even when coming into the center wasn't advised. Next slide. Looking at the health centers' change in the insurance mix of their patients, we saw a significant increase in the percent of their patients on Medicaid, due in part to the continuous coverage. We expect to see that percentage rise even higher when we look at 22 data. This is concerning as we look at the Medicaid unwinding and likely coverage losses. Next slide. We anticipate Geiger-Gibson Center at GW did an assessment of the impacts of the change in Medicaid coverage on community health centers specifically. They estimate that over 16,000 community health center patients will lose coverage. The Urban Institute did a similar report for the Medicaid systems writ large. They estimated about a 40,000 patients who will lose Medicaid coverage in DC. I actually think that's going to be even higher than what Urban indicated, because they were looking at numbers on Medicaid in 21, and those numbers have continued to rise. So a new estimate is probably closer to 48,000, but 16,000 of those are community health center patients. Geiger-Gibson has estimated the upper bound revenue loss for health centers at almost a little over 24 million, the lower bound estimate at almost 13 million. This is important because it will lead to loss of staffing. And when staff gets cut, that means less capacity within the health centers. So upper bound estimate, they will lose capacity to serve about 12,000 patients, lower bound about 6,500. Next slide. Just a little snapshot of some preliminary select clinical outcomes changes between 2019 and 21. It's really important that we provide you with 22 data once we have it, because we can't really claim trends at this point. Councilmember Henderson, I know you have very particular interest in maternal health, and the increase in low birth weight is concerning. We will come back to you with 22 data. I think it's important to understand that change is not the result of a change in entry into prenatal care during the first trimester. We saw actually an increase in the percent of health center patients who were pregnant who entered in the first trimester, yet still saw a decline, an increase in low birth weight. Some hypothesis around that, the pandemic was incredibly difficult and stressful for pregnant people. And, something we need to keep a very close eye on. Some declines in preventive care as well. Next slide. Just some lessons learned. Clearly, social drivers were exposed by the pandemic. There were specific policy actions the district took that made a big difference and that were undertaken at the federal level. We need to think about how we maintain those strengthened safety nets as we move out of the PHE and really reflect on what those policy actions were and their impacts. Definitely the pandemic stress exacerbated some of the mistrust of the health system and some ineffective communications at the federal level increased that mistrust. So we need to think about how we rebuild what's happening between residents of the district and the health system that cares for them. Next slide. Again, echoing Ms. Bowen's comments, health workforce challenges predated COVID, but they have intensified. For example, Unity Healthcare, one of the largest FQHCs in the country, currently has close to 20 openings for physicians and nurse practitioners. Mary Center, 17 openings for behavioral health clinicians, many of those in school-based health centers. Lastly, the health system has learned it is resilient, that communication, collaboration, flexibility, and innovation are possible. We need to continue to look at opportunities for innovation and how do we build upon what came out of the pandemic to create a more integrated direct clinical care and public health care system. Thank you.
Thank you so much. Ms. Schlossberg.
Thank you, and it's a pleasure to be here in person. Thank you, Madam Chair and members of the Committee on Health. And thank you for the opportunity to share remarks today regarding the end of the federal COVID-19 public health emergency and its impact on district residents and providers who serve them. Today, I'm going to focus primarily on the impact of the unwinding on the 63,000 district residents whose Medicaid eligibility is determined using non-MAGI income methodologies. The now MAGI cohort includes 33,000 seniors and people with disabilities, including nursing home residents, and approximately 5,400 residents who receive long-term care services and supports through the state plan. Actually, it's more than 54. If I include the state plan people, it's more than 5,400, and through the Medicaid home and community-based waiver program. As the district begins the unwinding process, these individuals already face challenges accessing needed care, and with the restart of Medicaid renewals are at greatest risk for losing Medicaid. At a high level, DHCF's plans for unwinding are reflected in a document posted on its website entitled DHCF's Operational Plan for Unwinding. This document contains two subtitles, both of which reference a return to normal operations, a theme which runs throughout the plan. As is well recognized, the COVID-19 pandemic has been highly disruptive to the U.S. economy and has fueled fundamental changes in how we live, work, and access healthcare. For healthcare providers, higher supply and energy costs and critical labor shortages in the face of increasing demand have placed them, to borrow a phrase from a recent McKinsey report I read, in the teeth of the storm. In the face of this storm, returning to normal pre-COVID operations simply fails to account for these seismic changes. We must consider and carry forward the tactics and flexibilities that have been critical to the ability of seniors and people with disabilities to access and stay connected to care, and that have kept providers afloat during these challenging times. Policy choices and how they are operationalized matter. I will focus on several key issues. First, and you've heard me speak to this multiple times, provider payment rates and staffing issues. During the public health emergency, DHCF sought and received authority to raise provider payment rates to account for higher staffing costs. These rates vary by provider type and have different expiration dates based upon the authority that was used to obtain CMS approval. District nursing facilities received a 20% rate increase, which will end in 2 months on July 11th, 2023. Intermediate care facilities for individuals with intellectual disabilities received a 15% rate increase. This will also roll back on July 11th. Assisted living communities received a 15% increase. This rate increase was scheduled to roll back on November 11th, 6 months after the end of the PHE. However, DHCF has agreed to keep it in place until a new assisted rate methodology could be developed and implemented. Home health agencies that provide personal care assistance received reimbursement for overtime, quarantine rates, and staffing agency rates, which according to DHCF ranged from 150% to 225% of standard rates. These payments will end November 11th. These rate increases have been instrumental in helping these providers meet increased costs during and since the pandemic. I'm trying to skip through this because I wrote a lot. And have been particularly important in addressing unprecedented staffing challenges. Not only are providers paying higher hourly rates, but due to the severe shortage of workers and higher turnover, they are relying on the ability to pay overtime and pay higher rates for agency staff. Predictably, the inability to adequately fund a meaningful wage increase for direct care workers in this budget cycle, coupled with the significant cuts in provider payment rates in the next 2 to 6 months, will significantly exacerbate the direct care workforce crisis. I have testified previously before this committee about even now providers who are refusing new admissions, who are taking beds offline, and who are literally closing beds because they cannot staff. Just the other day, I was told the Department of Aging and Community Living every day receives calls from district residents who are waiting for a home health aide to provide needed services. Simply put, once the post-PHE provider rate cuts go into effect, we anticipate that significantly more seniors and people with disabilities will be without needed care. This will also impact the hospitals. Renewals. Another significant area of risk for seniors and people with disabilities is the resumption of annual renewals. You've heard a lot about the process, so I won't go into that. DHCF has to begin the process for Medicaid renewals. They started April 1. For the vast majority of non-elderly and non-disabled beneficiaries, the MAGI eligibility group, DHCF has very successfully implemented a passive renewal process, which has been in place actually for even before the pandemic, which means beneficiaries will have to do very little to stay connected to Medicaid. DHCF, as you've already heard, anticipates a 77% passive renewal rate for the MAGI population. Unfortunately, passive renewal is not an option for most of the non-MAGI population. DHCF anticipates over 33,000 cases involving mostly seniors and people with disabilities who will not be able to renew passively. As a result, to complete the renewal process, these non-MAGI seniors and people with disabilities, and I brought a copy, must complete a 44-page conversion renewal form. It's in paper, a PDF, and produce supporting documentation to verify eligibility factors such as residency, income, and assets. For those receiving long-term care services and supports, both under the state plan and waiver, they will also need to complete an additional 18-page long paper supplemental application form and several additional forms, a total of 65 pages. For those applying new, that is not renewing, but new applications, that application actually is 89 pages. These renewal applications, and there's been a lot of concern and criticism about the length and the redundancy in these paper applications and the fact that there is not an online version that allows for dynamic completion of the form so that you could move through it more quickly. These renewal applications have to be submitted through a new partner portal and DC Direct. However, only nursing homes, ICFIDs, the PACE program, United Healthcare, and EPD waiver case managers have access to the partner portal. Assisted living providers, adult day health, and home health providers do not. This is because DHC believes that these providers have a conflict of interest, and while they can help fill out the paper form, they actually cannot upload the documents into DC Direct. Individuals receiving state plan long-term care services and waiver services, EPD waiver services, or PACE will also need a new level of care assessment from Liberty Health. This is the first step to apply for or renew long-term care Medicaid. However, with the return to in-person assessments effective last November, a process that is supposed to take only 5 days, the Liberty assessments are taking weeks and months. That is still an issue, even as late as last week, I am hearing about assessments that are scheduled 2 months out. So I have more to say. I wanted to talk about 6 observations and recommendations, which are at the end of my written statement. I do want to just affirm, I think what I heard Joan Alker talking about is the need for better data, particularly around staffing issues, around wait times, around processing times, that DHCF has created a renewal dashboard, but I think more detail in that dashboard and the ability to drill down into specific groups of individuals would be much more helpful. I also want to talk about the need to simplify this application. It is just too complex, and the need to rely more on technology to make this a simpler process. And lastly, DHCF is doing a lot of outreach. They are planning some outreach, for example, to senior centers and feeding sites. But I am tremendously concerned about the people who don't go to the feeding sites and to the meal plans. We have a lot of homebound seniors, or people have a difficult time leaving their apartments or wherever they're living. And I do not see a plan that's really designed to reach out to them. And then I just want to make a statement that DHCF needs to use better
We'll
use
ask
of
you
its
some
website.
We'll ask you some questions.
Okay. Thank you.
Okay, thank you. Dr. Bathgate.
Hi, Suzanne Bathgate. I'm the president of the Medical Society of the District of Columbia, and I thank you for the opportunity, Madam Chair, Councilmember Parker, and the committee for the opportunity to speak on behalf of the nearly 10,000 physicians in the DC area. We, as physicians, have faced a number of challenges, and I'd like to group them into a couple different categories. The first would be workforce, and we've heard a lot about this already this morning, but from the point of view of physicians, the pandemic upended pre-2020 assumptions about the oversaturation of healthcare workers in DC. Additionally, we are seeing the impact of delayed healthcare, such as preventative healthcare in 2020 and 2021, and that catching up on that delayed healthcare is going to tax healthcare facilities for years. This comes at a time when healthcare workers are experiencing burnout and moral injury from constant trauma care. The competition for workers is also high. A healthy healthcare workforce includes all types of practices, and primary care local practices must be a conduit into the healthcare system. If residents have access to a primary care health facility, whether FQHC or local physician office, we'll have a stronger healthcare system. If hospitals are the first point of contact in all medical cases, our healthcare system cannot be sustained. DC needs to double down on its commitment to a healthy, innovative healthcare system. This may mean taking a hard look at things like medical malpractice liability monetization and reducing the daily paperwork burdens faced by healthcare facilities and providers. The next challenge I'd like to talk about is office space. The lack of workers, not medical workers, but workers in general in the District of Columbia is harming the medical community. Previously, people working in the district have made medical appointments in the district because seeing a doctor over lunch after a shift is convenient. But what we're seeing is many people who sought their healthcare in the district are now seeking that healthcare in the suburbs. And what that does is destabilize the practices in the district. They don't have that income to sustain their practices. If people continue to work from home, especially from neighboring states, they will seek their medical care there. And we're definitely seeing that. The next area I wanted to talk about is social determinants of health. We as a society are good at forgetting the lessons we learned in crisis. During COVID, we saw clearly there are massive disparities in health across the region. Epidemiologically, we need to remain vigilant because it's unlikely this will be our last pandemic. Remember, SARS in the early 2000s looked like what COVID eventually became. We also need to strengthen the social safety net to ensure that all residents have access to culturally conscious care, good nutrition, and information about easy healthy lifestyle habits. For instance, MSDC and MedStar Family Choice are partnering on our community health programs, where a physician gives practical advice and information on common health topics to Medicaid beneficiaries. This gives residents access to take away better health tips. Everyone in the healthcare world needs to support Medicaid and Alliance re-enrollment. Notifying and helping individuals re-enroll is essential to the health of the district. We have heard this throughout the testimony this morning. And lastly, I'd like to speak a little bit about the DC physicians can serve the regional population through telehealth and regional license reciprocity. We thank the DC government for making both possible, but urge the council to remember that these are important health measures. Thank you again for the opportunity to testify.
Thank you, Dr. Bathgate. And thank you to this panel of witnesses. Just so you all know, we've been joined by Councilmember Brianna Nadeau. Councilmember Nadeau, we're going to do 10-minute rounds. And so Councilmember Parker is actually here in person. And so we will get to you once we get there. All right. So like I said, thank you guys so much for being here. Just a couple of follow-up questions. Ms. Quinn, what are you hearing from your centers and members around patients' uneasiness in terms of no longer having access to free tests, free masks, free vaccines?
We haven't had a lot of communication from the health centers about that worry, in part because health centers distribute some of that to their patients. It's worth asking, and we can go back.
Will that continue?
As long as it can continue. They have funding outside of the sort of billing and Medicaid funding from HRSA that they can utilize, but that's winding down as well. And we can certainly touch base with them and find out what their plans are for ongoing supply to the community for those things.
Right. Ms. Bowens, you talked about in your testimony a little bit the impact of the Medicaid re-enrollment on hospitals. And one of the things that I guess I'm concerned about is that the first place that a resident might find out that they no longer are covered are when they in a hospital, in a doctor's office, or at the pharmacy trying to execute on any number of things. Mm-hmm. And so what, if any, communication is being sent out to hospitals around what to do in that particular case with that patient?
So first of all, we would see a patient. So if patients certainly would come into an emergency room or come into a doctor's office. So all of our hospitals, for the most part, have people on staff that they work with who would immediately connect that patient with a process in order for them to enroll. So we have people on staff, financial aid counselors, who would automatically work with that patient to get them connected to the process to get them enrolled. And we are already working with our hospitals and directly working with healthcare finance to get the information out. So we're actively working in that process to actually provide them with the information and work with them as counselors. So we already have that process in play. Mm-hmm. So that's something that we do all the time.
Okay. I'm going to ask this is like me foreshadowing for DC Health. I'm going to ask a question around what we're sharing in terms of our various boards and providers around what to do if somebody shows up and then not covered, like the Board of Pharmacy. What happens? Ms. Schlossberg, so one of the things that stood out from your testimony, and obviously your written testimony is much longer, is the length of this application. Yes. Is it paper?
So DC has, as you know, has invested heavily in technology around eligibility systems.
And the definition of heavily is $600 million.
Yes. And I actually was in the department when we started back in 2011 building those systems. However, when they finally converted the old system, they shut down ACEDS and converted the people who were left in ACEDS, which were primarily these non-magi. They were not able to bring in a significant amount of data around those people. And so in order to get these existing people into the new system, into DC Direct, they are requiring a very lengthy application. And my understanding and what I have tried to learn about the system is that this application cannot be filled out online. I mean, basically you have to, it's a PDF. You fill it out. I think it is fillable online, but then you have to.
So we
submit it.
spent $600 million on a form or on a system. We still have a form that's PDF that can be filled out on a computer, but still has to be printed, which means that somebody at the agency has to then do data entry.
That's my understanding. I mean, again, I don't have a ton of visibility into the internal processes anymore. I am just, from the experience of the people that I work with who are trying to either renew applications or get people into the system,
Okay.
initial applications. The initial application is actually 66 pages.
Great.
plus
We're
18
I'm
pages.
foreshadowing to healthcare finance if you're listening, because I'm gonna ask Director Turnage about this when he gets here.
And I will tell you, because I've looked at the 18-page long-term care application and either the conversion renewal or the initial application. There's a lot of duplicate entries that you have to make, including things like your name or your preference around languages or your income and assets. So again, I think, and I've heard this from many people, there may have been a better way to design these forms, even if they had to.
And it's not a federal form, like
No,
we
not at all.
designed it.
DHCF designed it.
Great. Interesting. Okay. So Dr. Backgate, I think you raised some issues in the similar vein. We've heard from all of the, right, workforce challenges, the need in terms of folks for licensing. You brought that up, Ms. Bowens, all of those things. We haven't voted fully yet on the budget, but the committee did add back staff to HRLA for the purposes of helping in terms of the licensing process. And then also, I know that Dr. Lewis had some really great meetings around April 19th and April 20th on compacts that can also help in some of the workforce pieces as well. And so, I think that's definitely something that is happening. But I guess a question I'll ask you, similar to what I asked Dr. Mighty and Dr. Nolan on the last panel, is, are you seeing a decline in people wanting to or entering the medical profession here in the district as a result of burnout from the pandemic? Or are we seeing more people leave as a result of burnout?
I'll answer that question in a couple different parts. So at least in terms of applications to medical school, we are seeing actually, and to training programs, we are seeing an increase. In part, this might be a shift because a lot of trainees are shifting away from places where abortion is no longer legal. And so they don't get training or access to that experience. So I think in terms of people seeking to become medical students or residents in training, we're not seeing a decrease in that. In terms of people coming to work in the district, I think we're having a harder time recruiting than we used to. And we definitely saw a increase in people retiring early, moving to concierge practice, moving to practice in suburbs instead of staying in DC.
So how do we reverse that or slow it down?
I think some of the things that I talked about in terms of making the district a more enticing place to come work. Some of that might be through a medical malpractice reform. That's probably not the primary way, but that's one way. Another way through paperwork reduction. But even more, I think, would be supporting staff. So we've similarly seen an exodus of medical assistants, of nurses, of sonographers, the people that support physicians. And so if we can make DC more appealing in many different ways for them, I think that will help.
Affordability. Just being able to live. Some of the issues that we confront is, we talk about livable wages, but, again, some of the things we hear about is just being able to afford to live here. That's a big issue in terms of, we experience people right now. We look at the numbers in terms of how many residents live outside of the District of Columbia who come here. And our biggest worry is how many times are people going to bypass other hospitals to come and work in the District of Columbia before they stop and say, you know what, I'm going to stay in Maryland or Virginia and not come into the district to work. We would prefer that people live here. And so how do we make it so that people could live here? And we have to make it more affordable. How do we have more opportunities for housing and other things like that? Those are things that are really concerning us as we look at more attrition outside of the district, whether it's also with respect to safety, that's also becoming a barrier because the workplace safety is an issue, affordability. Those are some of the things that we're seeing on the perception side that are becoming some of the reasons that they're leaving the profession.
Yeah, I think that it's becoming more and more that we're having to sort of think about, especially I don't think a lot of people realize the numbers of like how many nurses don't actually live in the district, but work in the district, or how many physicians don't actually live in the district. When we saw, I think we got the numbers from the boards, it's stark. And so I think when we talk in the same way that we think about social determinants of health, when we think about the other determinants of somebody taking a job, whether it be what is my commute like? What is the time like when I'm there? You know, all of those other things. I think those are components.
And it's important that people would like to live in the city. So and it is not, people would like to live in the city, but often they just can't afford to live in the city. So, how do we help? How do we make it a place that they could return? And some of those reasons are certainly affordability is one of the reasons that we often hear that they would love to make it easier and not have that commute, but affordability does become one of the barriers to that.
Yeah,
I would add for health centers, excuse me, that's particularly important because we want the people in the health centers providing the care to be the people who are coming in, that concordance in your physician care is really showing up to be a major factor in positive health outcomes.
Mm-hmm.
And if we keep making it difficult for that to be true, it's going to hurt it's part of the health center model that we have this kind of connection to community. So I think what the city looks at in terms of affordability will impact our workforce.
Yeah, I think, and I'm turning to my colleague here. I was reading a Bloomberg article that was talking about interest rates. And if we were to write a report of all the things that have been impacted due to the pandemic, it's kind of crazy how from health, which is obviously the most natural thing because we were talking about a virus and a disease, but all the residual pieces that now are needing recovery or impact because of what happened. Councilmember Parker?
Ms. Bowens, it's great to see you again. And I'm going to pick up with you. It was staggering that you said approximately 50% of DC residents are seeking delayed care. And if you could just speak more about the material challenge that is posing on our healthcare system, that would be helpful.
Yeah. So it was staggering. We actually did our own survey and together with the Urban Institute, and we looked at delayed care. Certainly when we experienced the pandemic and, everyone was all in terms of doing whatever we needed to do to ensure that we had capacity. And there was a lot of fear. And people stayed away because of fear, other concerns. And also, we had directives around not doing certain procedures, elective procedures and others. And there was a lot of confusion in that space. And so people, didn't come in for a lot of their procedures and they delayed care. And we're certainly playing catch up. And what was the definition of quote unquote elective and non-emergent? So did that mean you didn't come in and get that screening that you need? You had a screening before and you didn't come in and get that biopsy. You didn't come in and get that follow-up. And unfortunately, a lot of people did not come in and those conditions exacerbated. And we're playing catch up in terms of you didn't come in and get that colonoscopy. And a lot of those conditions, unfortunately, for a lot of people, were worsened as a result of that. And so those were the impacts of some of that delayed care.
And we certainly got some challenging statistics from
Yes.
Dr. Bathgate and that I want to follow up with.
That's right.
But Ms. Bowen, in terms of the discharge challenges that
Yes.
regional hospitals are facing, can you compare what's happening in DC to other regional hospitals? Are we doing about the same, better, worse in terms of discharging patients on a timely basis?
We are, to my understanding, doing worse. We're doing worse. I mean, we are seeing, and I know several of
What
my.
exactly, sorry to interrupt, but what exactly is contributing to that in DC?
Well, what we are seeing in the District of Columbia, we're seeing some problems largely with insurance companies in terms of getting approvals, in terms of authorizations have been a problem. Authorizations have been issues. We're having issues with respect to being able to discharge to post-acute nursing homes and being able to have approvals there. I don't think there was a lot of thought, and again, not intentional with respect to our alliance population, aging and where we could admit patients. We've got issues with respect to some of our behavioral health patients and who's willing to accept those patients. We've got restrictions in terms of whether or not those patients, if we're full, if those patients can go to out of state. We've had just myriad issues in terms of being able to take a patient outside of the hospital and whether or not they'll be received. As you know, and I'm sure many of my members have talked to you, we've had patients who've stayed 300 days, 500 days, and others. So it's largely been being able to transfer them out to a receiving facility together with pre-authorization and other issues with respect to sometimes denials on the part of an insurance company. So those combination of issues have contributed to the problem.
Yeah, I would love to follow up with you about that.
Of course.
Dr. Bathgate, you shared statistics around clinical outcomes, and one of the focuses for me around opioid overdose deaths, it was staggering to see what is roughly 67% and 67% increase from 2019 to 21. And I know you don't want to talk about trends just yet, but what are some of the things that the district should be thinking about in that space in particular, as we are combating what I think is an epidemic that we're not quite giving it that name?
Another correction, Patricia Quinn, also not a doctor.
Okay, got it.
And you would not be the first person to call Dr. Quinn medicine woman in a hearing.
Yes.
But I'm assuming the question is for me.
Yes.
Thank you.
Yes.
That is one place where we can speak of trends, because we have data that shows another increase in 22. I think an additional 20-ish overdose deaths. So I'm sorry.
And more, what should we be thinking about in terms of solutions that we are not doing enough of? I can imagine the reasons why we're seeing such an increase, especially coming out of the pandemic. But what about solutions?
One thing that we're really watching very closely and are particularly concerned about in the loss of Medicaid coverage is pharmacy and people's access to medication-assisted treatment, both in terms of the ways in which they were able to access that treatment during the pandemic via telehealth. We're hoping that door stays open at the federal level, where you can initiate medication-assisted treatment via a telehealth visit rather than requiring an in-person visit to prescribe that. But there is something particularly devastating about someone going up to a counter to get buprenorphine for their opioid addiction and finding out that they no longer have health insurance coverage and cannot get access to that medication. People who are in recovery from opioid addiction have to have that. And we run some pretty serious risks if we don't have some stopgap ways of providing life-saving medications. So I'm concerned that about how that number might increase, because it's certainly not the only option, but people do turn to street access if they're not able to access their medication. So we're concerned about that.
One of the things we've heard a lot about in recent months are harm reduction sites or injection sites. And what you just mentioned, I think could broaden the conversation a bit. Often those discussions have been around places for people to do drugs safely. And we don't think about the care aspect of those that are trying to withdraw from using drugs, that they still need a place to go for care, especially when there are barriers to insurance and other forms of medical care. So anything you want to add to that ongoing debate around the benefits of harm reduction sites? And I'm not going to ask you to endorse them, but just what might be possible by establishing centers where people can receive that type of care.
Absolutely. And that is the vision behind harm reduction, is that you try to keep people alive long enough so that when they are ready for treatment, they're still here. I mean, that's the goal. Keep them alive until they can accept treatment and thrive. So DCPCA does support many of the harm reduction strategies that are under consideration, and health centers want to be a part of that. Many of our physicians are MAT providers and have found they have great passion for providing that care to their patients. And we would love to remain part of that conversation with you.
Yes, thank you for that. Ms. Schlossberg. I too found it really shocking to hear about the application and having to print all of those pages. One of the things I wanted to follow up on separately, though, was the passive renewals, and how many people you're saying, roughly 33,000 folk that are not eligible for passive renewals, and what policy solutions should this committee consider to help address that?
So the way passive renewals work is DHCF is able to ping or access other data sources and information they have in their own data systems to look at income and residency and immigration status and all those eligibility factors. And there are policies around that. So if income has gone up, I don't know, 10%, but it's within a reasonable compatibility standard that DHCF has established, then that individual is still eligible for Medicaid, and the person just gets a form that's saying, if this is all right, we're done with the process. And that has worked well in the district and actually has worked well for many years, even before the pandemic. This was all put in place post Obamacare. That was not done for the non-Magi population, for individuals whose income is counted using different rules. This is all based on federal requirements. And DHCF is moving toward that, but they don't have the key data points in their system yet, which is why we have these long, lengthy forms. So I think it's a two-step process. I don't know that you can, we can't create the ability to do passive renewals for the non-Magi population without the information being in the new system. I am suggesting, however, that there could be ways to simplify getting that information into the new system. In addition, there are other, it's almost like an all hands, there are other people who can help. Right now, DHCF, for example, is expecting that case managers will help all the 5,400 people on the EPD waiver. Some will do that. Some will do a great job. Some will not. The providers who are caring for those individuals, whether it's an assisted living or a home health agency, don't have access to DC Direct. And therefore, if something is not happening that should be happening, they should be able to help
Thank
get that information into the system. So
Thank you for that.
it's a
I
two-step
am well
process.
beyond my time. I would say, Dr. Rathgate, apologies for the mix-up. And I hope to get a question in my next round. Thank you.
Councilmember Parker, we're not gonna do
Oh, we're
a
not
full
doing-
another, so if you want to get your question in now.
I just wanted to ask you to speak more about the medical liability modernization proposal that you spoke to and what that might entail.
So in regions where there has been tort reform, there are reductions in non-economic losses or in payments for that. And DC is not one of those places. So there's insurance companies and physicians are more exposed to non-economic losses from malpractice claims.
Gotcha. Thank you.
Thank you. Councilmember Nadeau?
Thank you, Madam Chair.
Hold on one second, Councilmember. We can't hear you. Okay. Marcus, they can hear her on the Zoom. We just can't hear her in here. Oh, so Councilmember Nadeau just texted me that she has no questions. So thank you so much for being here. And we will take a 5-minute break. And then when we come back, we'll have Dr. Lewis and Deputy Mayor Turnage. Thank you.
Hey, BJ, this is Marquez in the chamber. B Jackson. B Jackson, there you go. Can I?
Testing, 1, 2, 3, 4. Testing. Testing, 1. Testing.
Hey, Jackson, can you say something and come on the video?
Testing, 1, 2, 3, 4, 5. Can you hear me at this point? Testing. Testing.
Can you come on the video?
Oh, I can come on the video. Testing, 1, 2. Testing. Testing, 1, 2. Testing. Testing. Testing, 1, 2, 3, 4. Testing sound in the room. Testing, 1, 2. Testing. Testing, 1, 2. Testing, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Testing sound in the room.
Councilmember Nadeau, are you there?
Yes,
Good, we can hear you now.
great. I'll be ready. Thank
Okay,
you.
sorry about that.
No problem at all.
Okay, and we are back. Thank you all for your patience as we took a brief interlude. We now have our government witnesses before us. Dr. Sharon Lewis, Interim Director for DC Health, Wayne Turnage, Director of DC Healthcare Finance, Melissa, who, no, I know Bird. Sorry, I didn't say that part, but I don't, your official title? Director of Medicaid. Oh, excuse me, Senior Director of Medicaid at the Department of Healthcare Finance. Before we begin, and you all know this now for you and your team, so anyone who might speak today, we need to swear you in that your testimony is accurate. So if you can all raise your hands. Do you swear or affirm under the penalty of law that the testimony you're about to provide the Council of the District of Columbia in this committee is the truth, the whole truth, and nothing but the truth? Great. Ladies first, Dr. Lewis.
Thank you. Check the time. Good morning. Good morning, Chairwoman Henderson, Councilmember Parker, Councilmember Nadeau, members of the Committee on Health, staff of the committee, and my public. My name is Dr. Sharon Lewis, Interim Director of the District of Columbia Department of Health, also known as DC Health. I am pleased to offer remarks today on the impact of the termination of the public health emergency, the PHE, and our transition to a post-COVID-19 pandemic world. DC Health's mission is to promote health, wellness, and equity across the district and protect the safety of residents, visitors, and those doing business in our nation's capital. Our commitment to this mission did not waver during the pandemic, and I am extremely proud of the work of our team, our partners, and our healthcare providers over the past 3 years. Their hard work and sacrifice ensured that the district is well on the path to recovery. DC Health had been preparing for a public health emergency since well before the COVID-19 pandemic. A core responsibility of public health is to prepare for and to respond to public health emergencies. Since its inception, our Health Emergency Preparedness and Response Administration has worked with other DC Health administrations, district agencies, and external partners to plan, implement, and direct public health emergency preparedness and response efforts for the district. These efforts were bolstered by the flexibility and funding that were provided by both Mayor Bowser's Public Health Emergency Declaration, which ended on February 22nd, 2022, and the federal PHE, which will end next week on May 11th. Thanks to our planning and support from district and federal government leaders, DC Health's comprehensive response to the pandemic included COVID centers, free and accessible testing, and vaccine accessibility second to none in the United States. We focused our outreach on vulnerable and hard-to-reach residents in the district and prioritized efforts to bring vaccines to them by partnering with healthcare professionals, faith leaders, and youth ambassadors. These efforts in both English and Spanish by our partners reduced vaccine hesitancy as they were viewed as trusted messengers and could effectively combat misinformation. Serving as the district's chief health strategist, DC Health developed a framework for addressing post-pandemic needs in 2021 and introduced it to the district through the COVID-19 Pandemic Health and Healthcare Recovery Report. This framework aims to assess the pre-pandemic, pandemic, and potential post-pandemic landscape of 5 functional areas critical to addressing the health needs of the district residents: health planning, workforce, health information technology, healthcare facilities, and community health services, with equity in programming and policy as foundation. We have issued new plans, such as the State Health Planning and Development Agency's annual implementation plan, to address the need for effective health planning. We have convened workforce stakeholders to identify new policies and practices for workforce development, established new scholarships, and expanded loan repayment programs to address workforce pressures. We have invested millions of dollars in public health information technology infrastructure. We also updated regulations and supported new healthcare facilities and community health services to meet the modern demand for telehealth services in an equitable fashion in this new post-pandemic normal. While we are proud of our work, there are several additional changes that would ensure an appropriate and robust response to future pandemics. Many of these changes must happen at the federal level, the source of the most public health funding and regulatory framework that governs much of the pandemic's response. There are also important strategies we will implement here in the district based on lessons learned over the past few years. With the PHE ending next week, we want to assure residents that we are continuing to protect their health by enhancing access to COVID-19 vaccination opportunities, as well as other important vaccinations, such as routine pediatric vaccines and influenzas. These include new enhanced walk-in COVID-19 vaccine access in partnership with Safeway and Cedar Hills Urgent Care, new grant funding to healthcare organizations to provide vaccine services to harder to reach populations, such as those homebound, expanded partnerships to provide pediatric vaccines, and a continued home vaccination program. As the funds supporting these activities are temporary, there is a need for a permanent funding stream to support vaccination infrastructure. Permanently authorizing pharmacists to administer Advisory Committee on Immunization Practices, ACIP, recommend vaccines for those aged 3 and older, and pharmacy interns and pharmacy technicians to administer COVID-19 and flu vaccines under a pharmacist's direct supervision to adults. This will increase the pool of eligible vaccine providers throughout the district, continuing to ensure that there are sufficient supplies, such as masks and tests, available to the public. We also continue to work with our federal government to ensure that access to COVID-19 therapeutics, such as Paxlovid, are available in the community. Continuing to track COVID-19 rates at long-term care facilities, jails, and add other high-risk facilities as necessary. We are working with area hospitals to automate hospital data reporting. While we do not plan to have the same level of public health facing dashboards as we did during the height of the pandemic, we will be implementing a new surveillance program this fall that will include COVID-19 and other non-influenza respiratory illnesses, in addition to our regular flu reporting. Updating and expanding telehealth through our revisions to the Health Occupations Revisions Act. District residents and patients will continue to be able to access telehealth in the district in a safe and convenient manner, as they have over the past several years. Finally, DC Health and the larger public health system has also shifted away from testing as the main mechanism for disease containment. Instead, all individuals who feel sick, regardless of the disease, should take steps to isolate themselves from others. This will protect our community, not just from COVID-19, but many other communicable and infectious diseases. One final note is that as of May 11th, when the PHE ends, access to Federal Emergency Management Agency, FEMA, public health assistance funding will end. This is significant as most of our COVID-19 response work was funded exclusively through federal reimbursement dollars. However, if there is a significant surge, DC Health will work with Mayor Bowser and the council to ensure there is access to sufficient financial resources to respond effectively. Thanks to the hard work of our team and partners, DC Health does not believe that the upcoming termination of the federal public health emergency will limit DC Health's ability or commitment to protecting the public health and wellness. I want to thank you, Chairwoman Henderson, for you and your colleagues' support of DC Health's budget and policy priorities as we work to grow the workforce and modernize our public health infrastructure. I would also like to thank DC Health's dedicated team of public health professionals, and I must say, they are a great team, and our partners for their continued efforts to support our agency's goals as it confronts the new post-pandemic reality. This concludes my testimony, and I look forward to discussing the end of the public health emergency and new post-pandemic environment with my colleagues and around the during this roundtable. So thank you all very much.
Thank you, Dr. Lewis. Director Turnage, thank you. And I just first want to say, we are aware that you all lost a team member at Healthcare Finance. And so we appreciate you being here today, and we'll try to get this done as quickly as possible so you guys can get
Thank you.
to that. Go ahead.
Good morning, Madam Chair, members of the committee. I have not prepared extensive remarks. I figured that time would be best served if we just listened and responded to your questions. I do want to say, after listening to the testimony before coming in, that I want to say at the outset that we recognize at DHCF that the job before us to manage this unwinding is enormous. It is massive, but it is very manageable. I do not share many of the concerns that were articulated this morning that seem to imply that we were on the precipice of some disaster. For sure, we are going to have to work very hard, as hard, if not harder than we always work. But we have the talent in the agency, and we have the technology to pull this off. Will there be bumps in the road? Of course there will be. But again, we have the talent and the team to respond when things don't go as they should. Let me quickly say on enrollment, and you've heard this morning, most of the enrollments will be passive. People automatically really have to do nothing. Our most vulnerable population, however, will have to actively engage in the process, but we know who they are. We have the data on the history of their service. And if all of a sudden we see that we are losing members that have years of service, months of service, that we see in the data, it's easy for us to reach out and say, do you need help to fill out your form? Melissa has already prepared for the fact by giving a 90-day grace period from the date your certification ends. So we're not going to sit there and watch the numbers drop in areas that we know they shouldn't be dropping and do nothing about it. That's just not the way we run the agency. Now, that said, people will lose coverage. If you look at the pre-pandemic enrollment levels, they were never as high as they are now, over 300,000 people. What people have to come to grips with, both providers, politicians, staff at DHCF, residents of the city, is that there are some people who will be moved off of Medicaid because they make too much money, even in a state where we have some of the highest income eligibility levels in the country. The options for the persons who are moved off are not grim. They can move over to the exchange and benefit from significant federal tax subsidies and continue their coverage. Now, it won't be cost-free as it is in Medicaid, but it is fair based on their income. On provider rates, frankly, I have a little concern about providers being used to the enhanced payments that we made. And then on date X, those payments disappear. But we have restrictions in that regard as well. The funding source for those payments ends at the end of this calendar year. If there's no funding source, we cannot continue the payments because we wouldn't get certified as having the money to pay the local share for those payments. So that is something that we have to deal with. Equally, we cannot just blindly continue enhanced rates beyond the period of allowance without respect to what the cost profile of the providers are. We cannot, under Medicaid, as a rule, general rule, pay rates that are higher than the beneficiaries, than the provider's cost. So that is an area that gives me probably a little concern, but we have a very, very talented team that our senior finance deputy, Angelique Martin, leads. They do robust data analysis every day. The providers that we deal with have excellent data systems. They know their systems. And if we get to a point where we realize that, hey, they're in some trouble, and they are legitimately in trouble, that they have adjusted their business model and they're still in trouble, then we can always go back to the mayor, to the CA, to the budget directors. Hey, we need to see if we can fix something. But as a rule, we're not going to start out by saying everybody keeps enhanced rates beyond the expiration of the funding source. So a lot of the concerns that were raised this morning, some are very valid. I think some are frankly specious, and I think some are overstated. So with that, I will end my comments and turn them over to you for any questions and the council member. I will say that I want to especially acknowledge Melissa Bird, because she has been working tirelessly with her team to make sure that we do this as best we can to minimize any kind of adverse impact. And so she's here to answer specific questions about some of the details of that effort. And I also want to remind people, from a technology standpoint and our data standpoint, we are the best in the city. I don't have any doubt about that. We have, under the leadership of April Grady, we have a data warehouse that CMS has said is one of the best in the country, and we built it internally. We have excellent data analysts. We have economists. We have actuaries. We are ready to do what needs to be done to minimize the impact of unwind. Thank you.
Thank you, Director Turnage. We'll do 12-minute rounds to give a little bit of time for colleagues. And it's actually great that you guys are both here so we can go back and forth in terms of questions. I'm going to actually start with the money, because that's where you both ended and started. So obviously, as you said, you both noted, a lot of the things that we did was funded via the FEMA reimbursement, as well as some of the other agencies' federal reimbursement, and that ends on May 11th. How much money are we currently waiting on for the federal government to reimburse us at this point?
No, we just get that money.
Yes.
Health Department or which one?
Doesn't matter.
Okay,
Dr.
go
Lewis.
first.
Oh, just turn your mic on.
Yes, I will ask Mr. Keith Fletcher, the Chief Operating Officer, to come forward to discuss that.
Mr. Fletcher, I don't know why you thought you were going to get through this hearing without.
Yes, although I do have the information.
Just introduce yourself for the record.
Hi, good morning. Keith Fletcher, Chief Operating Officer.
Okay.
We have submitted one reimbursement request for about just under $5 million. That brings us through January. We will submit one more reimbursement request that will bring us through 5/11. That will roughly be about the same amount. So the district's contribution should be just under $2 million.
Okay, and so you have like a week to get that last reimbursement and we're gonna meet the deadline, right?
No. You have until.
So we can build right up to May
Yes,
11th?
absolutely. And then you have, I think through September to actually get the reimbursement.
Okay, so we have one more.
So we have a couple more days of eligible expenses.
Okay.
But it's something that we monitor with our financial unit every 2 weeks.
Okay. One of the things, I guess, in the funding piece, and Director Zeilinger isn't here, but you are Deputy Mayor / Director Turnage. One of the things that we had also been using the FEMA funds for were the Pet B sites, as well as some of the hotels. So what happens with those costs? Because I imagine we're not removing people
That's correct.
from those sites.
And I am,
If you just-
I'm at somewhat of a disadvantage because nobody does that job better than Director Zeilinger. Her plan is to close the Pep B facilities. And we specifically asked, does that mean people will be put on the street? And she said, absolutely not. Now, I will say that, you know, notwithstanding her enormous talent, there is some skepticism about whether or not we will be in a position to close all of those facilities and make sure people do not end up back on the street. So it is a moving target. Right now, they're working fiercely to close the facilities and make sure that people have permanent housing. So we have to watch it closely. And I think if we get to a point where we're on a glide path to close facilities, but people aren't being placed in homes and apartments, then DHS will come back to us and say we need to come up with a different plan.
So how are we going to pay for it though?
Well, that's something that we'd have to come up with the executive office of the mayor, the city administrator, and the mayor. Because those hotels are not cheap. And the monthly, I don't have the data in front of me. You caught me a little bit off guard. The numbers that I last looked at were pretty high.
Okay.
So
Do you know an estimate of how many people we're talking about?
And again, I say this, I know I'm on the oath, so don't lock me up if I get this wrong. But
Estimate. That's why we're saying estimate.
I think 600 people come to mind.
Okay.
Um,
Can we just follow up?
yes, I can easily get, I can, if my chief of staff, Kiana, is listening, or somebody at DHS, we can get that number before this hearing is over.
Okay, great. So let's talk a little bit about access to tests, vaccines, and treatment, which is obviously, not obviously, but it is one of the sort of flashpoint things that people are talking about, residents are concerned about, especially since we have stopped the distribution at the libraries of tests. We have stopped the PCR home testing. We now have closed the COVID centers. And there is some anxiety around what happens if individuals still desire to test before they go out or test after they come back from a trip and they can't necessarily afford to purchase those materials. But Dr. Lewis, I have asked you this like 6 different times, but I feel like people still aren't hearing us. What was the rationale for closing the COVID centers?
Well, what we noted, well, one, we were very happy the fact that we were able to have a COVID center, one in each of our wards. So that's all of our 8 wards. And we did that throughout the pandemic. We did close them at the end of March. That decision was made based on looking at utilization. The utilization had waned considerably. However, what we did do, and we did send out a message to our residents via a press message. And what we did inform them is that we still have 3 areas where they can go and get their free antigen test kits. They can also get their vaccine, the COVID vaccine, as well their flu vaccine. So those 3 opportunities, one at Safeway on L Street, and then a Safeway that's located on Georgia Avenue. That's Ward 4, and then Ward 6. And then we also have an opportunity in Ward 8 at the Cedar Hill Urgent Center. So I will say that I just happen to have numbers.
I was going to ask you, how's it going?
Yeah, so I will say that they have been, a number of people have come to get, especially the antigen, the rapid test kits. So at the Safeway in Ward 4, actually, we have distributed 1,294. What I'm also excited about, we've had 74, we did administer, or 74 COVID-19 vaccines were administered, 8 flu vaccines. The Safeway in Ward 6, 33 COVID vaccines, 1 flu vaccine, 934 antigen kits. At the Cedar Hill, 9 COVID vaccines, no flu vaccines, but 2,134 antigen kits. So they have.
At the Cedar Hill site?
That's at the Cedar Hill Urgent Center. That's, they're on Martin Luther King.
No, I know. I'm
Yeah.
just, the idea that their numbers for the antigen test kits are higher than the other
Yes,
two wards. So
that's
that means that
correct.
people are most certainly using them.
Definitely. That's
Okay.
definitely, yes. So again, we're trying to make sure, and we will continue to evaluate the utilization even at those three areas. And make future decisions of what we will do post a couple of months. So we're looking at that at the end of this month.
Okay. In terms of purchasing these particular items, the tests, masks, vaccine, et cetera, are we now paying at cost? And by that, I mean, I'm not sure if did we ever receive some type of discount from the manufacturers on these products? And now that the public health emergency is over, will we basically have to pay the shelf price for this?
So I'm going to ask Patrick Ashley to come forward so that he can talk about how we were able to secure the antigen kits, as well as what we're doing with some additional ones that we have in surplus.
Okay, Patrick, if you just introduce yourself for the record.
Sure. Am I as loud as Keith was? Okay. Patrick Ashley, Senior Deputy Director of the Health Emergency Preparedness and Response Administration. So in short, we worked with OCP during the pandemic to do bulk purchasing of supplies that supported not only our COVID centers, but our employee wellness programs and other programs. So for example, when we purchased COVID antigen tests, we initially purchased 6 million of those tests at a cost of $60 million. That is slightly below market. And so, but not substantially below market. As we look at additional purchases, we would have to renegotiate with those vendors to see what the going price on the market is. That's done through the Office of Contracts and Procurements. We have not purchased any substantial supplies in quite some time because we made significant purchases.
Okay, so let's talk about what we have left. So DC Health reported that as of April of 2023, there were about 700,000 rapid antigen tests that were left in DC's inventory that will expire in December. And that this does not include the DCPS inventory for back to school testing. So what's our plan for distribution? Will those 700,000 go out via the pilots for the 3 sites that Dr. Lewis was talking about?
So we have a couple different sort of avenues there. One, we've maintained a strategic supply of those that's not included in that 700,000, just so that, you know, we make sure that we're prepared for any changes in what we're seeing in the community so that we can react quickly. We also have provided some of those supplies to some of our partners, such as Safeway, such as Cedar Hill Urgent Care, so that they have those supplies to give out. And then we've also worked with OCP and their surplus program, which makes those kits available to the to community not-for-profits for them to be able to access those resources through that surplus program. We've been directing interested not-for-profits to that program, and OCP manages that distribution.
Okay. I guess I'm not entirely sure which agency talks about this, but at one of your budget oversight hearings, someone mentioned that DC residents will still have access to affordable options for obtaining vaccines. Can someone say more about this, what those options are?
On the Medicaid side?
I can speak to the Medicaid Alliance and Immigrant Children's Programs will continue to cover vaccine, testing, treatment, et cetera, throughout. I mean, I don't expect that to change at any point soon. Specific to vaccine, we also made the policy decision to continue to reimburse it higher than other vaccines. We reimburse at 100% Medicare. We've made that permanent. And so we hope that it continues to encourage providers to make the COVID vaccine accessible to Medicaid beneficiaries.
Thank you for that.
Yes, and in regards to DC Health, I will ask Dr. Farley to share some of the things that we're doing and also to share about the homebound program that we have.
Dr. Farley, if you could just introduce yourself. I know you, but
Yeah,
the
Dr.
people.
Tom Farley, I'm the Senior Deputy Director for the Community Health Administration at DC Health. The COVID vaccine is free through the federal government through December 24. And so it's going to be available at the same sites it's available now, pharmacies, healthcare providers primarily. And we are also providing additional access through funding, as you heard, those sites at Safeway, and the Cedar Hill Urgent Center. And we have applications that we're reviewing now for organizations that will do vaccination of hard to reach populations. And then in addition to that, we have the homebound vaccination program where people who can't leave their homes at all can call up and individually have someone from DC Health come and vaccinate them. All that will continue.
For the homebound, is it only for COVID? So let's say you're homebound, but you also want to get your shingles vaccine at the same time.
Yeah, it's only for COVID right now. We don't have the mechanism to purchase and then bill for the other vaccines.
Okay. All right. I'm over my time, but I just want to make it known for folks, because we did have a public witness who testified at a budget hearing, I think for DC Health, that the cost of the vaccines being $130, they felt that it would be cost prohibitive. And I think you're testifying, Dr. Farley, that the COVID vaccine, the federal government is keeping it free until December. So for individuals who are looking to get vaccinated, that is still an option that is available to them.
Right.
Great. Councilmember Parker?
I want to pick up there. The vaccine will be free until December, and at those sites, are you following that same schedule?
That's through December 24 is my understanding. Someone correct me if I'm wrong in there, but I'm sorry, the question.
The 3 sites, the Safeway and Cedar Hill, are you keeping with that same schedule?
Yes, and I should be clear that the COVID vaccine is available at many more sites than those. So
Yes.
Approximately 40 pharmacy sites across the city offer COVID vaccine. Healthcare providers across the city are offering COVID vaccine. Those 3 sites are walk-in access. You don't need to have an appointment, low barrier to make sure that people know that they can just walk in and get vaccinated.
But on December 24th, they will no longer be free at the Safeway and Cedar Hill sites.
You know, that's the current plan from the federal government. That's December 24. Now, I'm assuming at that point that people are going to be able to get reimbursed through health insurance.
Yes.
And so we still have to deal with the uninsured at that point, but it's a relatively small fraction of the district that's uninsured.
And
So
Dr.
let me ask
Yeah.
for clarification on your question, Councilmember Parker. Are you asking whether or not we're going to keep those sites open until December?
It was the cost, but that's
the
a great,
cost.
that's a great prompting. So how long will you keep those sites
See what
open?
happened? No, I that's what I thought that you were leading to. So I just wanted to remind that what I had stated is that we're looking at the utilization of those sites, and we will reassess that at the end of May. There's some future opportunities that I know that Dr. Farley's administration is looking at, because they are looking in total for immunization compliance within the district. So I just wanted to make sure that we
So
were
just to
clear
make
on
sure
that
I'm
part.
clear, is there a date to close down those sites, or?
We have not identified a date certain.
And you'll monitor utilization. And how did you land on those 3 sites?
We engaged a number of potential providers across the city, and these were the providers interested in doing it. We asked specifically about providing access in east of the river, as well as in more of the downtown areas. And that's where we
Got it.
ended up with those.
Thank
I
you.
should be clear on that we expect that there will be a new vaccine that's going to be released in this fall, let's say September. And so we anticipate there's going to be an increase in demand at that point. Right now, demand at those sites and across the city is low. We're about 1,000 vaccine administrations per week versus 20,000 a few months ago. So currently there's not a lot of need for that, but we are putting the mechanism in place to make sure that we can do this for the anticipated surge in the fall.
And is there a possibility that you might open more centers?
If there's a need for it, we think that between the existing pharmacy and healthcare sites and these sites, there probably will not be a need, but that could change as the variants change.
Dr. Lewis, we heard earlier that the reporting requirements are a strain on health systems. You talked about your work with these systems to, I guess, update or relieve some of the requirements. Can you just speak more in depth on what the requirements are now, and what is your vision for working with health systems across the region in the future?
So what I will say is that we have been working with our hospital partners, as well as our DC Hospital Association, as well as DC Healthcare Association. Actually, there was a meeting that was held within the last few days with them, and we did discuss data and how we're collecting and what we're requesting of them. I will say internally within our office, we're looking at what we're asking them to provide to us and to see if there's any redundancies. Actually, we had that conversation within our executive leadership team yesterday. So we will be reaching out to them. We do not want to put a strain on our health system. We want to make sure that they're out there providing the right services to our patients within the hospital settings or long-term care settings, whatever. But I must make sure that it is clear that there is a requirement for them to post information into the NHSN, which is a federal system, and they must do that on a regular basis, and that's for patients. What we're looking at in decreasing as far as requesting reporting would be on the staff within the healthcare settings. But they must continue to report out on the disease entities for the patients.
Understood. And I know it used to be daily reporting, if I'm not mistaken. Where are we now with the local reporting requirement?
Yep. So once again, we are assessing that and we are going to pare down on that, but we are assessing that and we will get back to our healthcare partners to let them know what.
But as of today, where are we? Is it still
They are
daily?
still reporting.
Daily.
Yes, they are. Still
Got it.
reporting.
Okay. You talked about the testing and treatment, and I guess we covered some of that. But we also heard the recommendation of targeting vulnerable populations, especially seniors and those with other pre-existing conditions. Can you speak to how you are specifically targeting seniors around the city? As we in the public health emergency, I know the sites exist, but how are you all working to target seniors across the city?
So for vaccination, we do think that the greatest demand is amongst people over the age of 65, and that's where it ought to be. We have the ability to communicate directly with those folks, and we have done postcards and robocalls to those folks, encouraging them to be vaccinated. In addition to our general media messaging, we anticipate that kind of general messaging will go out again in the fall when the new vaccine is available, as well as this kind of individually targeted messaging. In addition, also to our work with community-based organizations that are trusted messengers.
Yeah, I would love to be a partner in that. So as you all are doing future outreach, if you can alert me, I will certainly do everything I can to share information with Ward 5 residents.
That's great. We appreciate that.
And I'm really glad to hear that you all are doing that continued outreach. And then Dr. Lewis, one last question here, and it's related to DCPS's test requirements. You talked briefly about the stock of tests that the LEA has. And I know some of this is within their discretion and decision-making, but are you giving any guidance for how long DCPS should continue their testing before returning back to school following holiday breaks or spring break, for instance?
At this particular time, we work closely with our OSCE partners in DCPS. However, it is their policy decision on how long they will continue.
But are you giving any guidance, recommendation? And if so, what are?
They have not asked us, but we are willing to do so if they do.
So what would you say? Because I hear from some parents that are saying, I don't want to keep testing my kids, although I personally think it's valuable. Is there a recommendation?
So at this current time, what I am aware of that when the students do go out on break, when they do return, the requirement currently is that they are tested to make sure that they are negative. I think that what we want to make sure is that our students are in an environment where they are not exposed to any type of disease process, maybe any type of respiratory disease. So if the child is sick, that the parent would keep the child home. So that would be our advisement.
Respectfully, I didn't hear an answer. So I will follow up with you on that. But I would love to understand if DC Health thinks this is a requirement that should continue, notwithstanding that it's a DCPS decision.
Yes.
Director Turnage, I want to follow up quickly on the PEP-V sites. And I know you talked about maybe you weren't fully prepared to answer that. I appreciate the dedication in trying to make sure everyone remains housed that are at those sites. And this was a concern that I expressed before in our
Sure.
oversight hearings. It's my understanding that part of the strategy there are those individuals are also going to be housed at DC Housing Authority.
Some of them could be, yes.
And what challenges might exist with the housing agencies or authorities saying they still have a number of units that are not livable, or and that they're trying to speed up the process of rehabbing units. They're trying to speed up the process of their own wait list.
Mhm.
So it seems like you have a system that's coming to an end while you're depending on another agency to speed up at the same time. Can you speak to the coordination between the work that you all are doing around the PEP-V sites, working with DC Housing Authority in particular?
Sure, and I preface all these comments by saying, when this meeting is, you should call Dr. Zeilinger, Director Zeilinger, for a more complete and probably more accurate summation. I will say that, and my staff did give me the numbers, they've been doing some good work. The numbers are down to 328 people in PEP-V, which is pretty good, because the last numbers I saw were over, I think they were over 600. And the cost based on the step down that DHS is proposing, the local cost up to the end of this fiscal year will be $14 million. With 328 people to house, yeah, there will be some reliance on DC Housing Authority, but there will also be use of the other opportunities, the other options that exist in the city system-wide housing program. So I don't think we have to look to the Housing Authority to swallow 328 applicants. But we
specifically, not to interrupt, well, my apologies for
That's all right.
interrupting. I know that DCHA is working to update its waiting list, and soon, very soon, they are hoping to open it up and get people into housing.
Sure.
I guess part of my question is, are you all saying save 50 units for us, 100 units, so that we can have a place for these folks and these PEP-V sites? That level of coordination.
Yeah, and that is a question I can't answer without talking to the agency, but my guess is, knowing how they operate, I'm sure if they're planning to use DC Housing, they are working on the numbers and what they would expect DC Housing to be able to produce. But I will get that answer for you before the end of the day.
And then in my last 40 seconds, I appreciate that you raved about the data systems. We heard testimony earlier about the paper applications.
Yes.
And the barriers that may pose to people. Can you just speak to why are we still, even after the significant investments that have been made, requiring people to print hundreds of pages?
And I'm not sure why this wasn't more fully explained this morning. It is a requirement to get the data in the system. It's a one-time requirement. The persons who have to fill out their long application are doing it so we could populate the data needed to run a one-stop shop application process for human services. Once that's done, they don't have to do that again.
And once that application is printed and submitted, is someone then entering all of that information manually?
No, well, again, if it's you can apply in several ways. You can do it through a portal. You go on and you can submit a paper application.
So you can do it online.
Yes, you can do it
Got it.
electronically.
Got it.
That is what we are hoping that people do. Now, I will say that Melissa just told me this before I sat down, was that we are incenting the case managers to make sure that we get our most vulnerable population enrolled. Melissa can give you the details, but there's a financial incentive. If you have members of our most vulnerable population on your caseload, then you get paid more when you get them re-upped for Medicaid.
Okay, I am at time. I'm hoping Councilmember Henderson picks up there, but thank you.
Yeah.
Well, Councilmember Nadeau is next.
Oh, I'm sorry.
So she might just see your to that
Okay.
and in front of you. There you go. Councilmember Nadeau.
I'm going to kick it back to you both. You covered pretty much everything that I was going to
Hang on,
ask.
Councilmember Nadeau.
Oh, again.
Okay, can you speak now?
Yep. Can you hear me?
Yes.
Great. I was just going to say, I'm not going to pick up there, but I will just kick it back to you all because you covered a lot of ground and my questions were I will say responded to. We may have some follow-ups, and some of that will be with DCPS and their policies. So thank you very much for convening us, Madam Chair.
Thank you, Councilmember Nadeau. So now I do get to sort of pick up on that. Okay, so let's talk about the application for a second. So I can go to a portal and register. Yes?
Yes.
Okay. If I do for Medicaid recertification, is that a paper process or is that an electronic process?
It can be both, but we prefer electronic. And if you're passive, you don't have to do anything.
Right. Okay. So how many people do we think are passive in our system?
About 67, a little over 60%. Historically, we were doing 80%, close to 80%. We expect.
You say 60%. Tell me real numbers. What does that translate to?
I can't think of the numbers off the top of my head. I know right now from our first month, I think we had 7,000 people already renew, and that's mostly passive out of the, I can't remember the top numbers, but across programs, we always look at this as a percentage. So we usually have been in that 72% of our MASHI population, which is the larger subset of our population that does passively renew. We expect that to be a little bit smaller, a lower percentage during the renewal process, just because of the expanded population that we have.
Okay. Is DC Direct and DCAS the same thing?
Yes, District Direct is the online portal and how a resident access the system, and the system, we call it DCAS internally, but District Direct is that portal, that kind of front page for a district resident to get their information to the system.
Okay. Are you all tracking times versus each other, right? So processing times for electronic application versus processing times for paper application, perhaps in a way to encourage more of the case managers or folks who may be working with folks on renewals to say, please do this online as opposed to doing this in a paper process.
I have to follow up for you on that one on the tracking. Part of it would come through us on the system side. And then part of it, if it's a paper application, we have to start with the Department of Human Services of when it comes into the system, but we can certainly look at that. I would say, we do have up to a certain time frame to process an application, but we certainly try to get it done before then.
Great. So earlier in the hearing, Professor Alker from Georgetown called out Minnesota as having a very good online data dashboard system. Separate apart from that, though, one of the things that she recommended was that healthcare finance release the data that they were required to provide to CMS on the 8th of every month.
Sure. So we have already, let me just step back. Transparency is one of our kind of aims as we go through this process for a number of reasons. One, just a public entity, but two, I do believe it builds trust with everyone that we're working with here. So we have our first, our renewal distribution plan, which was the first thing that was due to CMS. It is on our website. Our eligibility or renewal dashboard went live this past Friday on April 28th.
Wait,
so
you have
that
a
is
dashboard?
We do. Yes. I told folks we'd have it in April. We have it in April.
Okay.
So it is live on our
when
website.
Councilmember Parker goes, I'm going to pull it up.
Okay, great. It's something that will be updated. Yeah. I think the next update will be mid-May. It doesn't tell you a ton yet because we're in that, first process, but you can see the number of beneficiaries who are up for renewal, the number of renewals that are complete. Last I saw it was 63% for the expectation. And most of those were passive. We had 2% of the population who had already renewed. That may not sound exciting to you. That was exciting to me because we're still just under 30 days out. And this was within 3 weeks of the mailings going out. So no, all that information will continue to be updated. We'll show folks who have it, the number of folks who have it renewed. And then as we go through the process, we'll update it as needed.
Are we going to disaggregate that data by beyond just who renewed versus not? So
yes,
whether it be demographics,
We
race,
can cut it any way you can think of.
Ward would be nice. I know we have a lot. I mean, I think in this particular case, I have ANC commissioners who are like, nobody takes me seriously. I want to do more. This is a great opportunity for us to utilize these wonderful elected officials in our city to say, hey, there are X number of people in your ward who are up for renewal, who haven't. So when you're sending out your emails and you're, talking on the listservs about trash pickup, also mention, hey,
we can cut the data by any demographic. We can do it by wards. You have to be a little bit careful by address or neighborhood because you don't want to run afoul of privacy requirements.
Oh, for sure.
But any other way that data, somebody might conceivably be interested in looking at the data, we can provide it. And the numbers you were looking for earlier, just on where we are, there were 17,000 enrollees who faced renewal on April 1. As of April 20th, 9,600 have been renewed. And 7,800 have outstanding renewals and they must take action.
7,800.
And some of those individuals, their renewal will be due end of this month and some will be due at the end of next month. Just because of notice requirements.
Okay. Are we doing more than just mailing? So if we have a phone number or email address on file, are we doing something with that?
Sure, yeah. So, the bare minimum requirement, federal requirements is that paper mail notice to individuals. So obviously we're doing that, but we are also, I think it started this week or maybe next week. We are doing robocalls. We are doing text messaging.
Okay.
I know you've seen the bus ads throughout town. We'll have some TV spots coming live soon.
Okay.
And then certainly we've been doing a number of events, whether it's television, radio shows, going out to ANC meetings. I think we were at the Southwest one this past Monday. So anytime someone invites us, we are trying to show up. And then we of course have our managed care plans who are doing outreach as well.
Great. All right. Speaking of dashboards, Dr. Lewis, when will the COVID dashboard be taken down?
So at this particular time, we are having discussions. We will send something out to our public in about 2 weeks. We will keep the cadence that CDC has, a weekly cadence to share any of the case rates with the public. We want to be very thoughtful in how we do take down the current information that we have, because we want to make sure that it's properly archived. And we are also excited about not only the changes that we will be making to the COVID dashboard, but also in the fall, we're planning to bring up a new, I'm going to refer to it as a respiratory dashboard. So we're looking forward to that. If you recall, during the fall of last year, they talked about the 3 respiratory diseases that we needed to think of. Yes, the RSV and the COVID, and of course the flu. So we're trying to be very thoughtful in what we want our respiratory dashboard to look like in the fall. So we've got a lot going on, not only making revisions to the COVID dashboard, but also the upcoming respiratory.
So in about 2 weeks.
In about 2 weeks, we'll get information out. Yes.
Okay. So at the budget oversight hearing, you stated that DC Health would look into whether or not the agency should post additional information on the website around options for COVID care outside of the centers. And what I'm sort of saying is, at least for a while, right? It seemed as though all of our COVID related information was housed on a different website than if I just went to the DC Health main page. Even if I clicked over, it was sending me to
the coronavirus.dc.gov.
That one. Yes. And so we've seen residents turning to creating their own Google Docs for COVID testing information, which I feel like, okay, that's great that they're being resourceful, but they shouldn't have to do that. Are we providing that information on our website in terms of here are our 3 pilot testing sites, and these are the times that are available for you to receive care?
Yes, and currently, if you do go to the coronavirus.dc.gov website, you will be able to see the locations of the 3 vaccine centers that, I did share, as far as the 2 Safeway locations and the Cedar Hill Urgent Center.
Okay. And you did say the data that's currently on the dashboard will be archived and can it also be made available, obviously with the right precautions and safeguards and agreement signed, to researchers who will be looking for this information?
Yes.
Okay.
Yes.
Great. So in terms of tracking of what happens going forward, seasonal peaks, et cetera, one of the things that the earlier panels were talking about was the need for continuous surveillance. I know DC Health, you guys went through a full process in order for us to set up the wastewater testing. Is that going to continue? And are there things that we have learned from what we have just gone through that you all will be applying as we go forward to seasonal peaks or other types of things?
Yes, and I can share with you a little bit about the wastewater. If you want more detail about the wastewater, then I'll ask Dr. Mangler to come forward. But with the wastewater, we are currently doing surveillance at 24 sites. With that, the information that comes from the wastewater surveillance is posted on the CDC website. I will also say that we're working very closely to engage Blue Plains, as well as being a partner such that we could include them in our surveillance of wastewater. As far as tracking of what's occurring here in the district in the way of any of diseases, there are required reportable diseases that must be reported to DC Health. So with that, we will continue to track and see what is actually occurring within the district. And if we have any of concerns, of course, we would immediately reach out to our resident population.
Okay, you said that the wastewater surveillance information goes to CDC and it's posted on their website. Is there anywhere that residents can access it from a district government site, or do we have to go to CDC for this information?
Let me check with Dr. Mangler to see if it's, yes, you can come forward.
Come on to the table. She's inviting you. Come on down. It's like the price is
This
right.
is one of his areas. He and Dr. Summers.
Dr. Mangler, if you could just introduce yourself for the record.
Good afternoon, everybody. My name is Dr. Anil Mangla. I'm the state epidemiologist for the district.
Great. So in terms of the wastewater surveillance information, Dr. Lewis said, you all have to send it to CDC. But I guess the question is, for residents, will this information also be available on our website?
Yeah, so that's a great question. What we're doing is right now the data is going to CDC. We actually have that 24 sites like Dr. Lewis has said. So we getting a website ready that's going to be more granular. This is going to provide information for the 8 individual wards. It's also going to provide information on 8 different public schools and 4 charter schools. We also add in the high risk, right? So when you look at it, you look at COVID, because of the transmission, congregate settings are very important. So we actually starting to do testing at the Department of Corrections, and we also will be doing surveillance at St. Elizabeth's. There's another 2 sites we're doing, and that's more broader sites. And those are going to be the watersheds, which is actually Blue Plains and Oxon Hill.
Okay.
So this gives us a really good picture of COVID in around the entire jurisdictions, and we can go to a granular level.
Is the wastewater surveillance only for COVID, or, because I've seen in other jurisdictions where they're like, there's some polio in the water.
Yeah.
We should deal with
So,
that.
so we could add many other components to it. People are looking at norovirus. People are looking at flu, as a matter of fact, right? So these are options we will able to add in due time.
Okay.
Right now, we really focus on COVID because we're already going to have that non-respiratory kind of surveillance, and all the surveillance and monitoring is ongoing.
Okay, but you said the website is coming.
We are working on that website, correct?
Okay, great. Councilmember Parker?
Yes. What the dashboard that you mentioned, where do I find that? Because I was unable to.
Sure. It's on the dhcf.dc.gov website. When you go to the main page at the very top, you'll see kind of a top line. It talks about MCO transition and Medicaid renewal. Click on Medicaid renewal, and then you will scroll down. Once you get to that page, close to the bottom, I have it on mine right now. We can put it on the front for sure.
Okay, I was gonna say, wow, this is
I know,
real
so we can
intricate.
put it on the front.
Down, click twice.
Yes.
Turn the page.
Put it right on the front of the agency.
Awesome. And I'm assuming the point of that dashboard is to monitor coverage. Are there, what indicators should we be paying attention to when we look at that dashboard to know something's not going in the right direction?
I'm sure. I think what will be most telling from the dashboard is once we get, within a couple weeks of the end of the month. So for this, May 15th or so, and if those numbers are still pretty low, for me personally, I would start to have some concerns for folks who are due to renew by the end of the month. And then there might need to be another outreach push. And that's where we would probably communicate with our managed care plans. Most of the folks who are due to renew by the end of this month are going to be in our managed care program. And so we would be pushing out that information. The other place for me where I would kind of make note of those changes or like kind of not the movement or rate of renewal that we'd like to see. We do have a biweekly community stakeholder meeting that's every other Wednesday afternoon. It's open to any and everyone. And that certainly we take that opportunity to push out messaging as well. And then through our certain providers who like our case managers that do have a responsibility for some of our members to be renewed, we'd be reaching out to them as
So
well.
it seems like we should be looking at coverage as it relates to on a monthly basis, who is supposed to be covered by the end of the month.
Yes.
Several weeks out from that, if we're not trending in the right direction, that's when we should be doing something different.
Correct.
Got it. Okay, that is helpful. And I'm going to ask Dr. Lewis the same question. So if you could prepare, but Director Turnage, one of the recommendations we heard earlier was that we should be capitalizing on lessons learned to build a more integrated health system. And can you just speak to how you all are doing that? Or what are some of the approaches you all are taking to build a more integrated health system?
Well, I am rather parochial when it comes to that issue. And my energies are, on the one hand, we've done some things to try to get the healthcare providers to gauge around financing models that would force them to integrate. Not had a lot of success for different reasons. But from where I sit personally, I am much more interested in what we accomplished in Ward 8. So my efforts are making sure, working with Ben Stutch and my in-house finance team is making sure we stand up the new hospital in Ward 8 and all of the antennas from that hospital, the ambulatory care facility, the 2 urgent care facilities, and then stay in Kim's stay on Kim's email to find out what kind of progress is being made in bringing other community providers into that system. You know, one of the biggest sins that I witnessed when I came in DC government, and it lasted for years, was the really disparate health experiences for the folks in Ward 8, and then the options they had for care in their community. They were not good. And I'm not blaming anybody, but when you look at what the sickest people in the city, with respect to their chronic conditions, have for access to care in their neighborhood, it was appalling. And so the other stuff, making sure you have community integration amongst the community providers is certainly a good and worthy goal. But my attention is on Ward 8 and Ward 7 and what's going to happen when we stand up that the first integrated healthcare system that the residents of that city will have seen in its history.
I appreciate that. One of the, just piggybacking off of that, respite care and the need for it to relieve some of the capacity issues our hospital systems are experiencing. What is the vision there? That how do we provide more respite care throughout the district so that folk are not staying 300+ days at a hospital?
Yeah, that's a challenge. That's another one of Melissa's projects.
Melissa is busy.
All I know is that the CEOs for the hospital called me and said, I have somebody that's been in here for 1,000 days or 365 days. And I'd say call Melissa. So Melissa, I'll let you answer.
Okay, no problem. Thank you for that, Deputy Mayor. I'm sure. I think from my perspective, it's not just respite care. We have larger issues for reasons why people don't have somewhere else to go when it's their time to leave a hospital or even a nursing facility. Some of the work that we've been doing right now is just really case by case. What we just recently started within the agencies, we have now a team of folks who are piloting like a weekly rounds with one of the hospitals in the district to look at their more complex cases so that we know earlier on when that person's ready for discharge, that the discharge planning is ongoing and we're looking at where we can assist and if we need to be more creative than usual. We are working closely with the Department of Behavioral Health in that work as well, because most of these complex cases or many of them that we see are coming forward with, it's not just a physical health, but a behavioral health issue too. That's oftentimes what makes finding a viable placement outside the hospital so challenging. Longer term, so that's kind of trying to get to like, how do we better manage that and better support the system from
And
internal?
before you go to that, and that's at the hospital center, is that correct?
Yes, that's our first pilot with hospital
And
center.
how are you sharing, if at all, learnings in the short term
Mhm.
from the work that's happening in that pilot
With hospital center or with everybody?
with everybody?
With everybody, I think we've only done this 2, maybe 3 weeks. So we're not at that point. I do know what likely happens, and I'll have to confirm this for you, is our folks work with the hospital association. There's a quality subcommittee or work group or whatnot. And I would expect that those initial findings to be shared through that outlet most likely, but I can confirm that for you. We also have a team internally that's kind of working with, I think they call it the HRTT team, the HEART team, is to look at folks who are more complex and have may be at risk of needing to go into a hospital or another institutional care. And what do we do? Kind of how do we identify them early enough so that we can get in the support so they won't need to get to that next level of care. So that's the longer term of how we're better managing those folks and before they need that care and then go in and maybe they have housing now, but they go in for a while and they lose that housing. So those are, they're not overnight fixes. We also know we need to build capacity within the district on the nursing facility side for folks who are aging, but also have behavioral health needs. And we, between myself, Department of Health and Department of Behavioral Health and the association have started those talks as well.
And I asked Ms. Bowens earlier to compare DC to regional outlets. Do you have like specifics on that you could follow up with in terms of how long folk are staying in our hospitals versus regionally?
All I have right now is anecdotal. When I talk to my colleagues in other states, so the Medicaid directors in all other states, when I bring this issue up, no one is like surprised. They have those same issues within their systems or within their states as well.
Okay.
I think the nuance for us is that because of the size of the district, we probably have more people who may end up out of district. Whereas a state may not have that same, may not be as common in the state just because they're geographically larger than us. So I think that's the nuance for the district.
I think there's some national, I think there's some measures. I know each hospital collects, very detailed length of stay data. And I think there are some national data sets that looks at it by region, but I'll double check and get back to you.
Yeah, that would be helpful. Dr. Lewis, one of the things we also heard about were the significant number of people that had delayed care. And it was, I think, estimated 50% of district residents who have some sort of delayed care. One of the things that I'm interested in, we've talked about this before, and you all put out a report on HIV rates and STDs and other diseases and how we were moving in the right direction, and that kind of backrolled during the pandemic. How are you thinking about both HIV, but other more life-threatening illnesses, approaching that while hospital systems are trying to catch up on those folks who had delayed care?
And thank you for that question. I will say, as you know, our HOSTA administration has been quite aggressive. In fact, they were recently at the White House to share with them some of the initiatives that they have been doing. We have been out in the community to make sure that our residents are fully aware of all of the services that we have, not only at our clinic, but also with the CBOs and other partners that we do have. Most recently, I think that you may also be aware that we are preparing for the upcoming Black Pride and Capitol Pride. We're going to be present there to make sure that we can support with vaccines and PrEP and make sure that other items are available so that we can meet the needs of the members that are coming. So I will say that as it pertains to HIV, we are trying to make sure that we continue to decrease. The numbers did go up a little bit, but we are making sure that we're out there getting the education out on the footprint, supporting our CBOs to make sure that we can bring those numbers back down. They didn't go up that high, but they did go up a little bit. I don't have the numbers
So
in front
two
of me
things
right
I would
now.
just quickly follow up. I invite you to join me at some of those events during Capitol Pride and Black Pride. I would love to partner with you all on that. And I also want to give a shout out to our chair, Councilmember Henderson, who did in the committee report put enhanced investments to help target HIV outreach, which is
Yes,
greatly
most
appreciated.
definitely. Thank you.
In my last 40 seconds, Dr. Lewis, I would give you the floor to just speak to residents who may say it is too premature to end the public health emergency. What would you say to them, and what should we communicate to residents?
So I would say to them that as we look at the numbers here in the District of Columbia, our numbers have been very low. We've been low level for months. So at that, I would say that we are truly coming close to an end. COVID will never go away. So what that means that we have to continue to keep up with our precautions, make sure that we maintain our infection control. I want to make sure that our residents are very much aware to continue with their hand washing. We want to get the vaccine. Most importantly, that is what's going to protect you, getting that bivalent vaccine. To also communicate closely with your primary care provider or with your health clinic that you may be affiliated with. With that said, I think that as we move forward in the future, what we're looking at within DC Health is going back to pre-pandemic and making sure that we shore up many of the other services that are available to our residents. We want to go back and revisit some of those diseases that are still pretty high up on our, like cardiovascular disease, for example, to see if we can bring that down, the cancer, to see if we can bring that down. If you look at COVID, 2 years ago, COVID was number 3. Now it's number 4 as far as the leading cause of death within the District of Columbia. So I think altogether, I want to thank our partners. We've all worked very hard to make sure that we're able to make sure that we're safe here in the District of Columbia and that we maintain that low level.
Yeah, and that will conclude my questions, but I just want to thank you all for the work that you did throughout this entire pandemic. And I can say almost with certainty, every person I've talked to across the district touts the work that DC Health did in particular during the pandemic. And so again, for saving lives, for doing tremendous outreach, and for all the work that you do, thank you.
Thank you.
Thank you, Councilmember Parker. I only have a few more questions and then we can get gone. Ms. Bird, I pulled up the website. Thank you for the roadmap. And it is nice. I mean, I think that I shouldn't have said that with such surprise in my voice. It's okay. It is nice. I think that providing, once you have more information, disaggregating this by race and ethnicity as well as by ward, I think will be helpful for folks in terms of how we perhaps we need to know where we do more targeted outreach to get folks connected as well. And the other thing that I would be interested in, I know that I can obviously ask Health Benefit Exchange for this information, but how many people per month are you guys referring over to them in order to get folks you didn't qualify here, that's okay. You don't have employer sponsored, that's fine. We're going to transfer you over and they can get you connected over. Okay.
As I listen to you talk, it dawned on me, it might be.
Your mic.
As I listen to you talk on this issue, you give me a really good idea. I think, dashboards are good, and, they tend to be folks, those who benefit are typically inside baseball people. One thing we did when there was a lot of questions around the managed care program and, what beneficiaries were getting for their money, we released quarterly reports on a whole range of metrics for managed care. Maybe what I will do, once we get a couple of months into the recertification process, during the time between now and then, we will develop a report template, and it will have all of the if you have suggestions that you would want to see, just send them to me.
Okay.
we'll put the table shelves together, turn it into a report. We'll probably do a briefing slide and just send it out like every month after the first 3 months of the enrollment period. And it will have, all the data, and then we'll end with, what are the questions that these data suggest. And we'll send them to all the stakeholders, council members, anybody who wants to, without having to go to a dashboard and try to figure out what those numbers say.
I think that would be great.
Yeah.
But now that we do have the dashboard, I do have some questions about, so it says about 25, the number of Medicaid fair hearings pending, 25 is the number. The fair hearings, I think we talked a little bit about this perhaps at oversight, but if you can refresh my memory, are those taking place in-house or are they taking place with OAH?
They go through OAH.
Okay. And so I'm assuming you all have had conversations with the chief judge over there to make sure that they have the resources necessary to handle an influx of cases.
Our general counsel works closely with the chief judge. And they have expressed concern, periodically about the number of Medicaid cases they get, but certainly she will stay in touch with them on this issue and certainly feedback to us any concerns that they might be raising.
Legally, how long can a fair hearing Medicaid related case pen for?
I think they're supposed to respond within 90 days, and I have to confirm that for you, but I believe it's 90.
Okay, so we already have some that are, we're already behind. We're just getting started, but I'm confident that
The one question, and I will get a clarification, if those are specific to eligibility, they could be for other things. Are the most common reason we see appeals are for changes in individuals' personal care assistance hours. So having a PCA in their home. So I would check, and we've seen even a few of those, even though we've stayed any reductions over the PHE. So I will check and see if we can tease out if those are specific to eligibility or for service changes.
Great. One of the things that an earlier panelist, Dr. Mighty from Howard, was talking about in terms of vaccines is that it seems as though we only do this vaccine push when we're in crisis. And therefore it makes people fearful, as opposed to us just having a constant conversation around, this is just part of healthy living and protecting yourself, right? Making sure you have your boosters or getting your other, whether it be the routine pediatric vaccines or whatever updates that you need as an adult. What's our plan in terms of continuing that messaging? So it doesn't seem like we are just being reactive, but we're being proactive around, this is a part of public health.
Yeah, that's more of a DC Health role. We will do what they tell us to do at DHCF. So I'll.
You can see Dr. Lewis's face. Yes.
That's right. Well, I will say, and it's interesting because I had conversation yesterday with our immunization administration, and that is led by Dr. Farley. That's one of the divisions within his administration. And what we're gearing up is really for a full campaign for this summer, because we want to make sure that our district residents are fully immunized, and especially with children, if we're getting, we want to make sure that we don't run into August where all of the parents are trying to get their children immunized. So we have already started that conversation. And it needs to, we need to look at the person as a whole person, whole body, not just the COVID piece.
Right.
And to make sure that not only do they get their proper medical care and screenings that they have negated over the last couple of years, but also get up to date on their immunizations. And that would be for all ages. So we're on board and making sure that we push out more communications in that regard.
Great. There was a reporter who reached out about a report that someone had did talking about DC being the highest with death per capita during COVID, second highest. After I think New Mexico, perhaps.
What is the name of that?
But one of the things that
Lancet.
the
Yes, is that
report,
the Lancet article?
Yes.
Oh, yes, we're preparing.
Okay.
We're doing our due diligence because that is not correct information.
Well, so when the reporter reached out and I was like, I actually took time to, I read the executive summary and then, did some skimming, but it was also like, something seems off about this report.
That's correct.
For a
Yes.
variety of different reasons, but also too, I think one of the things that it does highlight, that I think we all can admit and need to work on continuously is that the district, although we had high insurance coverage rates, we also had a number of individuals who were dealing with comorbidities that we didn't know would lead to severe COVID at the time, at the onset of the pandemic, right? So we deal with high levels of diabetes, high levels of heart disease, high levels of asthma and hypertension, right? And so when you combine it all together, it's like the perfect worst storm of outcomes. And so when we talk about immunizations, I think we also still have to talk about how do we keep people healthy in general, so that if there is a new virus that is introduced to our environment, it doesn't become more deadly.
Yes, well, I will say that I was much disturbed when that article was presented, that was on news media. And immediately we talked about it at DC Health, and we are doing our own statistical validation of how they came up with this number.
Okay, great.
But I will say that the number was extremely high, probably 50%. So we will do a rebuttal to the article, and I'll make sure you get a copy.
Great. I'm all ears because I feel like, well,
Thank you. We did a great job here in the district. I mean,
I
it
felt that we
was-
did a good job in
Yeah.
comparison to lots of other jurisdictions. And frankly, whether it be the testing rollout, whether it be the COVID centers, you can get masks, you can get free tests. Like we had some hiccups at the beginning, but I felt like we worked out the kinks and continued to provide good information and tried to ensure that we had very good care. I want to briefly ask you about provider readiness. I have maybe 3 more hospitals to go through in terms of touring. All of them talked about how they have now sort of equipped their units to be able to expand and contract based on surges. From a hospital standpoint, and Director Turnage, maybe in your deputy mayor hat, you can weigh in on this. Do you feel like our hospitals are prepared? Should we reach another surge and needing incapacity?
That's a good question. I will say that their level of preparation is greatly complicated by the residual effects of the last pandemic on staffing. We have got to find a way, and Dr. Lewis has been working on this. I use make it less onerous, not to imply that the system we have is too onerous, but for lack of a better term, we have to find a way to make it possible that they can attract staff easier without undermining quality. Because right now they're still struggling with the fact that they have a difficult time keeping nurses, and they have to pay a lot of money. And so if they got hit with another surge like next week, another pandemic, this year, it would be a challenge for them. It'd be a huge challenge, and it would require all hands on deck to make sure, because hospitals typically do well, but I know all of them are struggling with their margins because of the high staff costs they've had to endure for like 3 years. So yeah, it would be a challenge, I think. But again, I would defer to Jackie Bowens for more expert comment, but I would be concerned if they had to turn around and respond and surge up, primarily because of the staff and the cost associated with it. I know Dr. Lewis may have another view.
So thank you. So we've been working with our hospitals in many ways, hospitals as well as the long-term care facilities, but I will now have my comments to the hospitals. We did support them during the COVID with the surge, and we did ask them to identify spaces such that if they had overcrowding concerns, where can we place patients? As you know, we are a certificate of need state. We work very closely with our state health planning and development administration, and they did issue waivers in some instances so that the hospitals could expand and accommodate more patients in lieu of the licensed capacity. So we did do that during the COVID. I will say that our hospitals have been very resilient at any time. If you think back to even Ebola, they made accommodations to make sure that we would be able to take in those patients, and they did the same with the COVID. So I think that we work very closely with them. I'm going to touch also on the licensing component because the workforce is very important. I think what we did see is that many healthcare workers did leave some of their full-time jobs and went to work with staffing agencies because they made more money. And now they're going back to their homes, if you will, to full-time employment. So I'm happy to see that. What I will say within DC Health, we issued 2,328 temporary licenses. As you know, we were trying to be very accommodating to professionals coming into the district to work, such that if they were licensed in another state in good standing, had a negative CVC, we gave them a temporary license until we could work through with them being able to give them a permanent license. As you stated early on in the very beginning, yes, we did keep our 2 dates. On April the 18th, Arian Gibson, the Senior Deputy Director for Health Regulation and Licensing Administration, and his team did meet with the Maryland and Virginia light boards. As you know, we have 19 professional boards. So there was a joint meeting with Maryland and Virginia and their professional boards. I will say that for the Board of Nursing, we really are trying to push forward to see if we can get a regional licensure agreement, but many of the other professions were also interested. We followed up on April the 20th and had a meeting with National Council State Boards of Nursing to talk with them about the compact and what would that mean, and to find out actually what are the requirements and all of that. So I will say that we're aggressively moving forward. And once again, I must state that we were so excited that with the Regional Board of Medicine agreement that we have been able to license several physicians with that program. So that seems to work. And that's one area that we really want to push, because we could remedy that quicker than the compact, because again, you have to have the IT infrastructure, the API connection and all of that in order to fully implement a compact.
Okay. And I'm sure we'll talk more about the compact pieces as well as talk about the HORA
Yes.
updates and those kinds of things.
And I did finish my review. It's in process. So I'm back and forth now with the attorney on a couple of items. So
Dr.
we're
Lewis,
making
you
progress.
said May was going to be a big month for us.
That's right.
In terms of the stuff that we
Yeah.
were supposed to be getting from a reporting standpoint. But you brought up the certificate of need, and I kind of chuckled because I brought this up with Deputy Mayor Turnage at his hearing.
I'm
Y'all-
gonna stop bringing up things that.
No, I know, but you know, y'all well, not y'all. There are differing opinions from one hearing to the other in terms of certificate of need. That being said, let's just briefly, as we end here, talk about telehealth services. And we've made lots of flexibilities in terms of the CON process around that. I was about to call you doctor.
I'll take the promotion.
You'll take the promotion. Okay. Director Byrd, can you talk a little bit about, are we seeing any changes from CMS in terms of telehealth coverage? I know that they really expanded access to telehealth during the pandemic. Are they about to roll some of that back, or what are we going to see happen there?
I'm sure the thing that's probably of most concern to providers in telemedicine, it actually comes through the Office of Civil Rights and the Health and Human Services Department. And it's some of the flexibilities that they allowed in terms of HIPAA compliant platforms. And so that that flexibility has been allowed throughout the pandemic. That will go away at the end of the PHE. So if a provider doesn't have a HIPAA compliant platform, so they're using iPhone or something like that, which I don't think has their BAA with the feds, and that becomes a challenge. But from the district perspective and Medicaid, prior to the pandemic, we had already identified or decided to reimburse or acknowledge telehealth as a modality of service. So meaning it doesn't matter the service, so long as you can meet the standard of care, whether it's in person or through telehealth, then we will reimburse at the rate that we pay for that. So that continues.
Does that include audio only?
Well, I was just about to get to that. Yes. The couple of changes we did make at the very beginning of the pandemic was to allow audio only and to allow home as an originating site. So prior to that, I had to be in a doctor's office, and then they would communicate, use telehealth to communicate maybe to a specialist. But now you can be in your home or you can be audio only. And we made those two components permanent. And so that will continue going forward, and we don't anticipate rolling that back.
Okay, great. I'll just say again, and I mentioned this earlier, I'm all for telehealth services, particularly on the mental health in terms of providing access. But I feel like we have a responsibility as government, as we're making this more accessible, to ensure that these platforms are doing the right protections around PPI. And the growing number of these companies that are being flagged by the Federal Trade Commission and otherwise for, non-protected practices or I think it's a little bit concerning.
Sure. I think a couple of things that are in our favor. The prior Federal High Tech Act did provide support to help providers meet meaningful use and give funding to have them adopt electronic health records that were certified by the federal government. We just expanded that program to include behavioral health and home and community-based services providers, so they have access, so that as they're bringing on EHRs or other technology, we are trying to line up as best as possible with compliant. The other thing I will say too, though, that we've done throughout the pandemic is continue to audit telehealth services, particularly on the behavioral health side, to make sure that the services are being used as we would expect.
Wonderful. Give me just a moment. Dr. Lewis, one other question. So at one point during the pandemic, you could get an antigen test from DC Health. Most people didn't realize that, but you guys also were a site for distribution. Are you doing that anymore or no?
For the antigen kits, you can go to the 3 sites that we have posted on our website.
So I can't go to the Department of Health to get a test?
A test kit or
A test kit.
No, we do not have it.
I'm just saying, I feel like some of our government agency buildings just have some, should someone come by.
So I think if I can, are you referring to an antigen kit or an antibody test?
Antigen kit.
So the antigen tests are the
eye
rapid.
health
Yeah, yes.
boxes. You used to have those.
Yes, we had those at the COVID centers. So they're the 700,000 we've talked about.
Right. But I'm saying, like, I think at one point I could go to the lobby of DC Health and I can get one.
You actually could never go to the lobby of DC Health.
Oh, no.
We had a restriction with our landlord that didn't allow us to do it there. For a day, excuse me. Yes, we got in trouble for that. So.
Oh, you got in trouble.
Yes, we did. It's a lease facility.
Understood. Okay. I'll let it ride. Wonderful.
But visit one of our 3 areas.
No, I mean, yeah. Yeah. Wonderful. Okay. So this concludes today's roundtable. Thank you so much for all of our witnesses for being here. This was a roundtable that only had invited public or invited witnesses to provide oral testimony. However, anyone can submit written testimony for the record. The record will remain open until Thursday, May 18th at 5 p.m. You may email your statements to astrange@dccouncil.gov or leave a voicemail at 202-430-6046. If you choose this option, please speak slowly and spell your first and last name for the record. I want to thank all of the witnesses who provided your time and insights today. I think that there is some anxiety in community around what it means for the public health emergency to end. And I'm hopeful that any residents or individuals who were listening to this hearing feels a little bit more comforted that our public health officials are doing everything possible to ensure that the unwinding of this public health emergency doesn't actually create other catastrophes within our healthcare system. So the time is now 1:14 and this hearing is adjourned. Thank you so much.